Hello everyone. A very good morning to all of you. I hope I'm clearly visible, audible.
A very good morning to all of you.
I guess it's working. Yes, I guess it's working. So I welcome you all for today's session. A very good morning to all of you. Give me a second. So today we all are gathered here to continue and finish our pharmacology rapid revision. We have already taken 2 episodes of pharmacology rapid revision and we have covered many important high yielding topics from exam point of view. The remaining topics we are going to cover today. So are you people ready? Can I start? Can we go ahead without wasting any further time? Can we start the marathon? So we have already covered the general pharmacology, the pharmacokinetics. Among the systemic pharmacology, the various systems, we have covered already some systems in episode number 2. That is, we have covered renal system, we have covered cardiovascular system. So today we are going to cover the remaining systems in a very easy way, in a very structured and easy way. So let me start with the most scoring system of pharmacology is the antimicrobial drugs. You can't imagine any exam, whether you are targeting FMGE, whether you are targeting NEET PG or NICT, whatever, or USMLE, whatever a medical entrance exam you are targeting, you can't expect your question paper without having a question of this unit. It's an ultra important, it's a 5-star important unit. So you cannot skip that. So let me start with this system. After finishing this system, we will come on other systems one by one. That is respiratory system, endocrine system, ANS, CNS. We are going to cover these today only. So let me start with the antimicrobial drugs. Can I start with the antimicrobial drugs? So I got many messages from many students that ma'am, please cover this portion in episode number 1 and 2. You have not covered this portion and it is very scoring. Believe me, it's very scoring and it's confusing also, but just give me 1 hour. In 1 or 1.5 hours, we are going to cover all the important antimicrobial drugs and short, at least 2 to 3 questions you are securing for your exam. Okay, so let me start. If you're preparing for your university exams also, this you can expect a long question from this portion. Okay, so let me start. So let me start with the antimicrobial drugs. So first of all, what are antimicrobial drugs? Achha, first of all, you tell me what are microbes. Antimicrobial drugs are the drugs which act against the microbes. So what are microbes? So there are 4 types of microbes. I'm sorry. There are 4 types of microbes. In the microbes, we can expect there can be a bacteria, there can be a virus, there can be a fungus, or there can be a parasite. So if I say I am teaching you a portion antimicrobial drugs, I mean the drugs that kill the bacteria, that is antibiotics, the drugs that kill the viruses, antiviral drugs, the drugs that kill the fungus, that is antifungal drugs, and the drugs that kill the parasites. So anti-parasite or anti-protozoa or anti-helminthic drug, the 2 types of the parasite. So these all together known as antimicrobial drugs. It's a big chunk, a big portion you can say. So we will take all the important points from this, all the important drugs from this. So let me start with the antimicrobial drugs. So if I want to kill a bacteria, how I can kill a bacteria? There are 4 ways we can kill a bacteria or we can kill a microorganism, you can say. Based on the mechanism of action, we classify antimicrobial drugs in 4 categories. What are the 4 categories? Number 1, by inhibiting its cell wall synthesis. Number 2, by causing the pores in the cell membrane so that its vitals leak out, the plasma leaks out, the cytoplasm leaks out, or by inhibiting its protein synthesis, or by interfering with the nucleic acid synthesis. Let me elaborate. Don't learn that. Don't learn. Have a look on this diagram. What you can see? Can you see something here? This is a cell. Which cell? It's a microorganism. It's one of the microorganisms. It can be a bacteria, it can be a virus, it can be a parasite, or it can be a fungus. You can consider for the ease of understanding it's a bacteria. Imagine it's a bacteria. Okay, this is the bacteria. You can see the cell membrane. Now, all the bacteria have the cell wall. So you can see blue color is the cell wall. So you can see the cell membrane. So this is the cell membrane. And you can see this is the cell wall. Okay, what you can see? This is the nucleus. Of course, this is the nucleus. Nucleus contains the nucleic acid. Okay, it can be DNA or RNA depending on the organism. If it is a virus, it can be RNA also. So you can see this is the nucleic acid. So I will call it nucleic acid, or it means it's a DNA. And what else? This is a ribosome. What is ribosome? We know ribosome is the factory for the protein synthesis. The protein synthesis takes place on the ribosome. Now see the structure. Now I want to kill this bacteria. Because I am a doctor and this bacteria is present in my patient, causing the disease in my patient. Being a doctor, my responsibility is to cure my patient, to treat my patient. To cure or to treat my patient, I want to kill this bacteria which is present in the body of my patient. So how I can kill so? How I can do so? I can do via 4 mechanisms. What are the 4 mechanisms of killing a bacteria or killing a microorganism? That is the classification. There are 4 ways. Please see. Number 1, I can give a drug that can inhibit the cell wall synthesis. Can you see the cell wall? I can give a drug that inhibit the cell wall synthesis. Cell wall synthesis. So all the beta lactams will come here. There are 4 types of beta lactams. We will take them in detail. There will be penicillin, cephalosporin, monobactam, carbapenem. All of them will come here. So number 1, we can inhibit the cell wall synthesis. Number 1. Number 2, we can give a drug that will cause the pores in the cell membrane so that the vitals, the cytoplasm will leak out. Now imagine if there are pores in the cell membrane, the cytoplasm will leak out and the bacteria will automatically die. So we are acting on the cell membrane and causing the pores in the cell membrane. That can be the second mechanism. Number 1, we can inhibit the cell wall synthesis. If the cell wall synthesis is not there, imagine there is no cell wall. What will happen? The bacteria will swell, burst and die. Okay, so cell wall is a protective structure around the bacteria. If there is no cell wall, the bacteria will die. Bacteria will swell, burst and die. Okay, so cell wall synthesis inhibitors can be there. There can be the drugs which cause the pores in the cell membrane, the second mechanism. Number 3, the third mechanism. There are drugs that inhibit protein synthesis, that act on the ribosome, that inhibits the ribosome. In the ribosome also, if you see from our childhood, we know there are 2 units in the ribosome, 30S and 50S. You know, there are 2 units in the ribosome. There can be 30S unit, there can be 50S unit. So various drugs acts on the 30S, various drugs acts on the 50S, various drugs acts on the junction of 30S and 50S, and ultimately they inhibit the ribosome. If there is no ribosome, no protein synthesis. So no protein synthesis is the third mechanism. Now imagine if this cell cannot form the protein. This will not die. This will not die because it already have the protein, but it cannot divide further. It cannot divide further into the daughter cells. You got my point? So protein synthesis inhibitors do not kill the bacteria, but they inhibit the cell division of the bacteria. So they are not bactericidal, they are bacteriostatic. You can understand. And last mechanism, there can be drug that can interfere with the nucleic acid synthesis. Now imagine if nucleic acid is not synthesized, the bacteria will die. So nucleic acid synthesis inhibition can be there. Here protein synthesis inhibition can be there. So now you tell me, how many mechanisms are there to kill a bacteria? These are the 4 mechanisms. I have shown you all 4 mechanisms in this diagram. Say, give me a thumbs up if you got it. What are the 4 mechanisms? What are the 4 mechanisms via which we can kill a bacteria? So there are many classifications, but based on mechanism of action, we can classify the antimicrobials in 4 categories. Number 1, there can be antimicrobials which inhibit the cell wall synthesis. They act on the cell wall and inhibit the cell wall synthesis. There can be antimicrobial drugs that act on the cell membrane and causes pores in the cell membrane so that leakage occurs outside and the microorganism will die. There can be antimicrobial drugs that act on the ribosome, and that's why they inhibit the protein synthesis in the microbe, and the microbe cannot divide further. There can be antimicrobial drugs that interfere with the nucleic acid synthesis. So nucleic acid synthesis inhibitors can be there. So if you have understood the 4 mechanisms, one by one we will take and we will see how many drugs are inside each of them, and we will see the details of that drug. So the first category I'm choosing is the drugs that inhibit protein synthesis. Can I start the drugs that inhibit protein synthesis? Are you people with me? Can I start the drugs which inhibit protein synthesis in the microbes, especially in the bacteria? So yes, let's start protein synthesis inhibitors. So before understanding the various protein synthesis inhibitors, there are many protein synthesis inhibitors. I will take 4 in detail. Tetracycline, aminoglycoside, macrolides, and chloramphenicol. So these are the 4 ultra important protein synthesis inhibitors. The mechanism of all 4 is same. I will teach you 4: aminoglycoside, tetracycline, chloramphenicol, and macrolide. One of the important macrolide is erythromycin. I will teach you all 4. These all are protein synthesis inhibitors. We will see. But the step is different. In all 4, the step they are inhibiting the protein synthesis is different. So my point is that before understanding their mechanism of action, if you want to understand the differences between mechanism of action of these 4 drugs, I will teach you these 4 drugs right now in detail, their uses, their adverse effect. But to understand their mechanism of action, you must understand normal protein synthesis. So have you read biochemistry? I guess you all have read biochemistry. In the biochemistry, you have read how protein synthesis takes place normally. So we will revise that quickly, the steps, and I will tell you which step is inhibited by which of them. Okay, so how does protein synthesis takes place? In the protein synthesis, there are 2 steps: transcription and translation. One is transcription and one is translation. What is transcription? This is DNA. So from the DNA, mRNA is formed. Messenger RNA is formed. This is known as transcription. Transcription is the conversion of DNA to mRNA. And from mRNA, amino acid chain is formed. This step is known as translation. In translation, the mRNA get converted to amino acid. I guess most of you know that, but we will revise that very quickly, brush up our concepts and go further. So how many of you can see a cell? I will show you with the help of a fantastic line diagram. Okay, see, how many of you can see this cell? This is a bacterial cell. Can you see this is a bacterial cell? Say yes. This is the nucleus inside the cell. Okay, this is the double-stranded DNA in the bacterial cell. Please see, this is a bacterial cell. It's not a human cell. This is a bacterial cell which is present inside the human body, in patient's body. We want to kill it. We want to kill it via giving the drugs, the protein synthesis inhibitors. So first see how the bacteria is forming the protein normally. Then we will see which step we can inhibit. Okay, so you can see a bacteria, you can see the nucleus of the bacteria, you can see the double-stranded DNA inside the bacteria. So what is the first step? The first step, the two strands in the DNA is a double-stranded molecule. One strand is leading, one is lagging. So the two strands get separated from each other, leading and lagging. You can see this is leading, this is lagging. So leading and lagging strands separate from each other. Okay. The leading and lagging strand separate from each other. That is the first step. That is the first step. Okay. The first step is leading and lagging strand separates from each other. Then on the leading strand, you can see the corresponding mRNA is formed. This is known as transcription. This is known as transcription. You can see the DNA from the DNA mRNA is formed. This is mRNA. You can see this is DNA, the complementary mRNA is formed. The complementary mRNA. This is transcription. Transcription takes place in the nucleus of the bacteria. Transcription. I will teach you 4 drugs now. Tetracycline, chloramphenicol, aminoglycosides, and erythromycin, that is macrolides. So none of them acts on the transcription. None of them inhibit the transcription. All of them inhibit the next step, that is translation. So we have to understand translation in detail. Now transcription is over. This mRNA will come out in the cytoplasm. After formation in the nucleus, this mRNA. So transcription is over. The DNA get converted to mRNA. This is done. Now this mRNA which is formed in the nucleus, it will come out. Can you see? So this mRNA which was formed here, it came out and go to the ribosome. So the next step will take place on the ribosome. You can see the ribosome. On the ribosome, you can see the mRNA. Now we will convert the mRNA into amino acid. And that is known as translation. That is ultra important. You have to understand the steps of that. Are you people there? Got it? Can we go ahead? Huh? So how does it take place? Let me zoom this portion. I will zoom this portion for you to explain you the various portions of a ribosome. Can you see a ribosome? I'm zooming it out. I'm magnifying it. So can you see this is a ribosome? In the ribosome, we are having 2 windows. One is P window, one is A window. Can you see this is P window and this is A window. In the ribosome, there are 2 windows and there are 2 portions, 2 fragments in the ribosome. This is 30S fragment, this is 50S fragment, and there is P window, there is A window. Now this mRNA came out and bind on the ribosome like this. Like this. So, you know, on the mRNA, this is mRNA. You can see on the mRNA, nucleotides are present. How many nucleotides are there? There are 4 nucleotides. What are the 4 nucleotides? Adenine, guanine, thymidine, and adenine cytosine. So these are the 4 nucleotides. They are present in triplets, and that is known as codon. I guess the basics you already know. So you can see this is the first codon, this is the second codon, this is the third codon. Codon is a triplet. It can be ATA, like that. Okay, it can be GTC, like it can be any of the 3, any of the combination of 3. You know, multiple combinations are possible. So codons are there. Okay, so the first codon always go to P window. It's a rule. And the second codon always go to A window. Second, and after that multiple codons are there. You can see this is C1, this is C2, this is C3, C4, C5, C6. That is codons. So first codon always go to P window. It's a rule. It's a rule. How many codons are there? You can see the 64 codons, various codons. So instead of T, there is uracil. T, thymidine is occurring in the DNA. Uracil is present in RNA. So you can see the codon can be UUU, UUC, UUA, UUG. It can be any. Okay, it can be any of the 4 nucleotides. That is adenine, guanine, cytosine, and uracil. Instead of thymidine, we are having uracil here. So you can make any of the codon. Okay, any of these possibilities are there. Okay, now you may be knowing that 1 codon codes for 1 amino acid. 1 codon codes for 1 amino acid. I guess every one of us, you know. Yes, so there are 64 codons. They are coding for 1 amino acid. There can be multiple codon coding for 1. Like all these are coding for phenylalanine, like that. Okay, so 1 codon stands for 1 amino acid. Now this is the basic rule. Now let me show you this. Can you see this? Can you see the cell? Again, this is a bacterial cell. Again, I have zoomed in. Here I have zoomed out to show you the magnified version. Now let's see the complete diagram. You can see a bacterial cell. Say yes. Inside the bacterial cell, you can see a ribosome. On the ribosome, you can see The mRNA is attaching. You can see the first codon is on P window, the second codon is on A window. The first codon is on P window, the second codon is on A window. You can see till that. Now what you can see in the cytoplasm? In the cytoplasm, all 20 amino acids are present. You can see this is A1, A2, A3, A4, A5, A6, A7. There are many amino acids, 20 amino acids. All of them are present in the cytoplasm of the bacteria. You can see, but they are not present like it is. They are present on tRNA. They are sitting. You can see tRNA is their transporter, their car, their vehicle. So tRNA. So they are present on tRNA. Okay, on the tRNA, this is tRNA. On the tRNA, amino acids are sitting. All the amino acids are present in the cytoplasm on the tRNA. Now, what will happen? What will happen? So, whatever codon is present on C1, on the P window, I will tell you now, there are 4 steps of translation. Let's start translation. You got the basic. There are 4 steps. Each step is inhibited by one of the antibiotic. So the first step is inhibited by aminoglycoside. The second step is inhibited by tetracycline. The third step is inhibited by chloramphenicol. The last step is inhibited by erythromycin, like that. So you have to understand the 4 steps very carefully. What is step number 1? Step number 1 is initiation. You say, ma'am, what do you mean by initiation? What do you mean by initiation? You can see here, whatever is the first codon, it is standing for some amino acid now. So they are calling that amino acid. For example, the first codon, you see the first codon is UUA, for example. UUA. Okay, the first codon here is UUA, and UUA stands for the leucine. So they will call, where is leucine, where is leucine? So wherever is the leucine in the cytoplasm, that will come and bind here. That is initiation. So that is initiation. So you can see the first codon is calling, you can see the first codon is calling for the first amino acid. So wherever is the first amino acid in the cytoplasm, it is coming and binding here. That is the first amino acid A1. That is step number 1, initiation. Okay, this step will be inhibited by aminoglycoside. I will tell you later on. So that is step number 1. Step number 2. Now on the A window, this was taking place on the P window. Let's come on the A window. The second window is the A window on the ribosome. On the A window, the second amino acid will come based on the second codon. Whatever is the second codon, whatever it is coding, that particular amino acid present in the cytoplasm, that will come and bind here. So A2, it is known as attachment of the new amino acid. This was the first amino acid and this is the new amino acid, new aminoacyl tRNA. Along with its tRNA, it is coming on the A window. So step number 1 takes place on P window and step number 2 takes place on A window. Please learn that. Please learn the windows also. Okay, on P window, initiations takes place, and on A window, always new amino acid come and bind. The new one, the second one, the new one. Step number 3, there is a bond formation between the two. So this is pre-existing amino acid, this is new amino acid. So peptide bond will form between the two. The third step, peptide number 1. You can see peptide bond will form between the two and the pre-existing will move on the new. Please mind my words very carefully. I'm not saying the new will move to the pre-existing. No. The pre-existing will move to the new. Look at the arrow. Appreciate the arrow, the direction of the arrow. You can see the direction of the arrow. So first a bond is formed between the two. Peptide bond between the two amino acid and the pre-existing will move on the new. So what will happen? P window will become empty. So after step number 3, the P window is completely empty. So this step is peptide bond formation between the new and the previous one. And after that, transfer of the peptide chain from P to A. So this shift is known as P to A shift. So P to A, from P window to A window, that is pre-existing to the new. This is normal. This is not. P window become empty. Okay. So this is step number 3. And the fourth and the last, please, you have to think 3-dimensionally for that. Okay. Please imagine 3 dimension. The complete ribosome. Can you see the red color ribosome? This complete ribosome. This one. It will move ahead. Yeah, ribosome ka ribosome aage jayega by 1 codon. The complete ribosome, please mind my words, please understand it. It's difficult, very difficult. So you can see the complete ribosome, this one. The complete ribosome will move further. See the arrow, it is moving by 1 codon. So my point is that whatever, it is moving further. So P window will come here at the A window. Okay, A window will come here. And this will become empty, the first codon. Okay, so P window, amino acid chain will be there only. It is not moving. The amino acid chain is not moving. Only the red color ribosome is moving. So amino acid chain, which is currently present on A window, if the ribosome will move further by 1 codon, so the amino acid chain will come on the P window. Because here, instead of A, the P is coming here. I hope you are getting it. See the next diagram. Can you see? So the C1 become empty. The complete ribosome is moved. So the amino acid chain is as it is. Where it was, it is there only. Now, the amino acid chain, instead of A window, it is coming on the P window. P window, and A window instead of C2 it is going on the C3. It is going on the C3. Again the steps are repeated. Again the new amino acyl tRNA will come. It will bind here. Again peptide bond formation will take place. Again the pre-existing will shift on the new one. Like that. It keeps on growing. And this is the 4 steps of the translation. This is the 4 steps of the translation. Yes? Yes or no? You got it? Yes, it is. The last step is known as translocation. Absolutely right. Punit, absolutely right. The last step is known as translocation. The complete ribosome is moving by 1 codon. So what are the 4 steps? What are the 4 steps? Can you enumerate the 4 steps for me of translation? What are the 4 steps of translation? Step number 1, initiation. Initiation takes place on P window. The first codon came on the P window. Second, new amino acyl tRNA will come. This step takes place on A window. Third, peptide bond formation between the pre-existing and the new, and the pre-existing will move towards the new. So this peptide bond formation and this shift is known as A to P shift. A to P shift. And finally, the complete ribosome is moving by 1 codon ahead. That is translocation, and this is known as P to A shift. Please understand this P to A shift. You can see now. You can see. This is A to P. You can see the complete ribosome is moving ahead now. So this is A to P. Whatever the amino acid chain is present on A window. But if the ribosome is moving by 1 amino acid, it is moving on the P window. So it is known as A to P. It is known as A to P. So please understand the 4 steps. Now I will teach you 4 drugs. You are ready to start the 4 drugs. First, everyone give me a thumbs up. All those who are live, give me a thumbs up that you got it. If you don't understand the normal, you can't understand the mechanism of action of these drugs. If you don't know the steps at all, how I can tell you that which step is inhibited by which amino acid? You don't have any idea about the steps. But now you know the 4 steps. All these drugs, whatever written in front of you, there are 4 drugs written in front of you: tetracycline, chloramphenicol, aminoglycoside, and macrolide. Macrolide are the erythromycin. They all do one thing: inhibit the protein synthesis. Okay, of course, these are protein synthesis inhibitors. Okay, the main drugs which inhibit the protein synthesis. They all inhibit the translation. There are 2 steps, transcription and translation. They all inhibit translation. So what are the 2 steps? First, DNA. From the DNA, mRNA is formed, and then from the mRNA, amino acids is formed. So this step is known as transcription, and this is known as translation. My point is that these all 4 inhibit translation. None of them inhibit transcription. They all inhibit translation. So they all inhibit mRNA to amino acids that is taking place on the ribosome. So all these 4 affect the ribosome only. Okay, none of them go in the nucleus. They all act in the cytoplasm and affect the ribosome only. But which step? Which step? So one by one we will see. Okay, again we will revise the steps, and correspondingly I will teach you which of these antibiotic is inhibiting one of the 4 steps. There are 4 steps now. One will inhibit one step. So the first step is initiation. Initiation takes place on A window. So you can learn A. A is A. A is the first alphabet in ABCD now. In the English alphabet, A is the first alphabet. So it inhibits the first step. You can learn like that. It is inhibiting the initiation because it is inhibiting P window. No P window, no initiation. Step number 1 is halted. No initiation. It frees initiation. Which? Aminoglycoside. A for aminoglycoside. So aminoglycoside, A. We represent it with the letter A. A for aminoglycoside, it inhibits step number 1. Because it is the first letter A, aminoglycoside, it inhibits initiation. Because why it inhibits initiation? Because it inhibits the P window. It damages the P window. No P window, no initiation. No initiation, step number 1 is not there. So what is the step number 2? There is another antibiotic, that is T. T for tetracycline. Tetracycline damage A window. Aminoglycoside was inhibiting the P window. Tetracycline is inhibiting the A window. No A window, so step number 1 will take place. Initiation, there is no problem in initiation. But step number 2 will not take place. That is new amino acyl tRNA cannot. So pre-existing is present. The pre-existing is present, but the new cannot come because this window is degraded or inhibited by the tetracycline. So tetracycline inhibits step number 2. It is inhibiting step number 2 so that new amino acyl tRNA cannot come and bind here. Step number 3, that is peptide bond formation between the two and shift from P to A. First, the bond will be formed between pre-existing and new, and then the pre-existing will shift towards the new. Pre-existing will shift towards the new, that is P to A shift. This is inhibited by chloramphenicol. Chloramphenicol inhibit none of the window, neither P nor A, but inhibit P to A shift. It inhibit P to A shift. It do not inhibit P window. It do not inhibit A window, but it inhibit P to A shift. Please understand that. That is step number 3. Step number 3. And the last step. What is the last step? The complete ribosome is moving ahead by 1 codon. the complete ribosome will move ahead by one codon. See, this is the ribosome right now. You can see this chain is present on A window. Now the complete ribosome will move ahead. This chain will remain here only, but the ribosome is moving ahead by one window, one codon. So this chain will come on the P. So it is known as A to P. A to P. A to P shift is inhibited by the last antibiotic, that is erythromycin, one of the macrolide or erythromycin. So this is the last step. So last step is inhibited. So I hope you got it. I hope you got it. So can you please help me? Can you enumerate? So step number 1, step number 2, step number 3, step number 4. You got the mechanism of action of the 4 antibiotics. Now only thing I have to tell you the uses and adverse effects. That's it. We are done with the mechanism of action. Okay, and we will make a master chart between the two, comparative table. So what are the 4 steps? Step number 1 is initiation. Initiation. In initiation, which window is affected? P window is affected. Okay, on P window initiation takes place. Step number 2 is coming of new amino acyl tRNA. New amino acyl tRNA on A window. Then the peptide bond form between the pre-existing and the new. So the third step is peptide bond formation between the two, between the pre-existing and the new, and shift of pre-existing to new. That is P to A shift. This is known as P to A shift. That is step number 3. And step number 4, the complete ribosome move ahead by one codon. That is known as translocation. Translocation. And in this, A to P shift takes place. Now you tell me which antibiotic inhibiting which step? So P window is inhibited by aminoglycoside. So aminoglycoside inhibit initiation. Okay. The A window is inhibited by tetracycline. So tetracycline inhibit the second step, that is binding of new amino acyl tRNA on the A window. P to A shift is inhibited by chloramphenicol, and A to P shift, that is translocation, is inhibited by macrolide antibiotics, that is erythromycin. How many of you got it? How many of you got it? Anyone have any confusion? I hope you got it. So let's start the chapter. So this was the beginning. है ना? अभी तो सिर्फ भूमिका बन रही थी. Now we will start the main chapter, the protein synthesis inhibitors. The 4 drugs are in front of you. You can see what we will see. So we will start with the tetracycline, then chloramphenicol, then aminoglycosides, and then erythromycin. I assume you already know the mechanism of action of all 4. So I will just enumerate the mechanism of action, which step they are inhibiting. You have already have the details. You have understood. The remaining things we will focus. So for each of them, I want you to make this master charts. I call them master charts. I call them master charts. In the master charts, we make a comparative table between the various antibiotics. So these all are the master charts. Can you see? These are the master charts. Okay, these all are the master charts you can see we will make. So for all drugs, this is a way to learn pharmacology. For all drugs in one particular category, you should make comparative tables between them. So I will tell you the introduction for each of them, then the classification. This is a category under which various drugs can come. The classification, then the spectrum they are covering, which bacteria they are killing, gram positive, gram negative, cocci, bacilli, anaerobes. You have to understand the spectrum. That is the most important. Then mechanism of action, then the mechanism of resistance, adverse effect and uses, the ultra important. For adverse effect and uses, you get maximum MCQs. So I will give you mnemonics here. 4 here, 4 here. Total 8 mnemonics I will give you. For most of the time, for adverse effect and uses, I will give you the mnemonics. Okay, so can I start? Let's start the first category and start filling this table with me. So I request all of you to take out your notebook, to take out your pen and start filling this table with me. So let's start with the first one, tetracycline. Can I start with the first one? Let's start with the first one, tetracyclines. Let's start with tetracyclines. Okay, the introduction. In the introduction, if any important point, you have to enumerate that. Why tetracycline is known as tetra? What do you mean by tetra? Tetra means 4. It is having 4 cyclic rings, like the benzene, 4 benzene rings. That's why it is known as tetracycline. You can see the structure. You can see the structure. That's why it is known as tetracycline. So this is the structure. There are 4 rings. Okay, nothing important, much important. Coming on the classification, tetracycline is a class. I mean, it is a category of the drug inside which various drugs are there. So we divide the tetracycline into 3 groups: group 1, group 2, group 3. Group 1, group 2, group 3. So how many tetracyclines are there? In the tetracycline, the first drug in the group 1 is tetracycline itself. The name of the category is also tetracycline, inside which one of the prototype drug is tetracycline. So the category is tetracycline, inside which the first drug is tetracycline, the second is chlortetracycline, and third is oxytetracycline. So tetracycline, what are the 3 drugs in group 1? Tetracycline, chlortetracycline, oxytetracycline. So these are the 3 group 1. In group 2, there is demeclocycline and lamicycline. And in group 3, there is doxycycline and minocycline. So 3, 4, 5, 6, 7. Total 7 drugs are there. You have to learn according to the group. Sometimes you get simple MCQs. So group 1, group 2, group 3. All of them are tetracyclines. So can you tell me? So here we have 3 drugs in group 1. Tetracycline, chlortetracycline, oxytetracycline. In group 2, we have only 2. Demeclocycline and lamicycline. In group 3, it's doxy. This is demeclo, this is doxy. Doxycycline and minocycline. So first of all, I want you to learn the classification, not only here, all the drugs and pharmacology. Step number 1. If you don't know ABCD alphabets, how you can spell CAT, CAT, BAT, BAT. Don't jump on the different thing. First, learn the classification. You should know the various drugs. If I say the name of any drug, you must know which category does it belong to. So in the entire pharmacology, you are having some important 60 to 70 classification. So my request to all of you, first of all, learn all those 60, 70 classification. If you can't learn, it's okay. You can read it. You can read it so that the drugs will be there in your subconscious mind. If it is coming in the exam, you will recognize, no, this drug belongs to this category. So take a printout of all the classification and stick it on your wall where you stay. So aate jaate jab dekhte rahoge na, you will see these drugs, so you will recognize them very easily. Okay. So this is the classification of the tetracycline. After classification group 1, group 2, group 3. You know the name of the drugs. Coming on the spectrum. How many types of bacteria are there? We divide the bacteria in 4 categories. What are the 4 categories? Gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli. Okay, apart from that, there are anaerobes are there, spirochetes are there, miscellaneous are there. So rickettsia is there. Now you tell me this tetracycline is effective against which category? Is it broad spectrum acting against all, or is it narrow spectrum acting against one particular category of the bacteria? I assume you read microbiology and I assume you know the classification of these bacteria. Which bacteria come under gram-positive cocci, which bacteria come under gram-negative. I assume you know the basics. Okay. So if I say any category, the bacteria should come in your mind that gram-positive cocci include what bacteria, gram-negative cocci include what bacteria. So you should know that. So tetracycline is the broad spectrum antibiotic. It is effective against all. It is the broadest spectrum, very broad spectrum. It is effective against all. So it is effective against all gram-positive and gram-negative cocci and bacilli, all 4 categories. So you see, I have written gram-positive cocci plus C, gram-positive bacilli, gram-negative cocci, gram-negative bacilli. So basically it is effective against all. It is effective. It is a broad spectrum and effective against all. So you have to see that. Being a doctor, you must know the spectrum of various antibiotics. So if any patient is coming to you, imagine any patient is coming to my clinic. So patient is complaining some UTI, some pneumonia, or some of the system involved, some of the diarrhea. So I must know the most common organism involving that system. Okay, the most common organism causing UTI in particular age group, in particular comorbidities, most common organism causing pneumonia, causing this, causing that. Now that particular organism is coming in which category and which antibiotic is effective for that. So you should know the spectrum. So this is like you should practice ethical practice. Okay. So this is a broad spectrum. So it will be effective in all the infections basically. Tetracycline. Now mode of action, you already know that. So first of all, you tell me from the 4 wild, the broad mode of action. Does it inhibit cell wall synthesis or it inhibit it inhibit the nucleic acid synthesis, or it causes pores in the cell membrane, or it inhibit protein synthesis? So ma'am, it inhibit protein synthesis. These all are protein synthesis inhibitors. So you tell me which step of protein synthesis inhibition. So number 1, it inhibit protein synthesis. It do not inhibit cell wall, do not inhibit nucleic acid, do not act on the cell membrane causing pore in that. No. It act on the ribosome and inhibit protein synthesis. It inhibit translation. Which step of translation? There are 4 steps. Now step number 1, 2, 3, 4. So it inhibits step number 2. What is the step number 2? Step number 1 was initiation on the P window. It do not affect that. Healthy P window. No effect on the P window. But it inhibit A window. No A window. So step number 2 is affected. Then the pre-existing amino acid is present here, but the new amino acid cannot come. The new amino acid cannot come. It act on the A window. It act on the A window. So it act on the 30s of the ribosome. In the ribosome also you have 2 portions, na, 30s and 50s. So tetracycline kahan pe act karega? Where it is acting, you have to learn. These all are your MCQs. Does it acting on 30s or does it act on 50s? It is acting on 30s. So you learn it is acting on the 30s and it inhibit the A window. It inhibit the A window. It is acting on 30s. It inhibit the A window so that the new amino acid cannot come on the A window. So step number 2 is inhibited. So protein chain failed to grow. So protein synthesis do not take place. So bacteria will not die, but bacteria cannot divide further. So it is bacteriostatic. It is not bactericidal, but bacteriostatic. So learn the summary. Number 1, it act on 30s, not 50s. Number 1. Number 2, it inhibits step number 2. That is, it inhibit the A window so that the new amino acid cannot come on the A window. And because of that, it is bacteriostatic. You know the meaning of the bactericidal and bacteriostatic. What are the drugs which are bactericidal? And what are the drugs which are bacteriostatic? What do you mean by that? Bactericidal are the drugs that kill the bacteria. And static are the drugs that do not kill the bacteria. But they inhibit them from dividing. So these are the drugs that inhibit them. So the bacteria cannot divide further. So this one is bacteriostatic. So this is the summary. So tell me 30s or 50s for tetracycline. Say ma'am, it's 30s. Which step out of the 4 steps? Is it A window or P window or P2A or A2P? So say, ma'am, it's A window. A window is inhibited. Since the A window is inhibited, new amino acid cannot come. Step number 2. And is it bactericidal or static or both? So it is bacteriostatic. It is not bactericidal. Okay. Now coming on the resistance is not important. You can skip coming on the adverse effect. What are the adverse effect of tetracycline? I'm having a mnemonic for you to learn. The mnemonic is LK Advani. Or you can say Advani ko Advi bana do. You can make Advi. LK Advi is PT teacher. It's a mnemonic. Okay. One more mnemonic, Kapil Dev Bat, whatever you use. The mnemonic, whatever you use, but full form is same. Anyways. So here L stand for liver damage. It causes liver damage. K causes kidney damage. Especially the demeclocycline will be safe here. Okay. So liver damage is there. Kidney damage is there. A is for anti-metabolic effect. It causes anti-metabolic effect. D is for diabetes insipidus. D for diabetes insipidus. V for vestibular toxicity. Inside the inner ear, the vestibules get damaged and person can have vertigo, tinnitus like that. Okay. So vestibular toxicity. I is intracranial pressure is raised. Okay. P is phototoxicity. T is, there are 2 T. Okay. One is teeth and bone. It get deposited on the calcium, form chelates with the calcium. Calcium is present on the teeth and bone. That's why it forms chelates on the teeth and bone. So it is never given in the growing children, small children. Okay. And T for teratogenic. It is never given in pregnancy. So can you tell me the mnemonic along with the full form? So what is the mnemonic? Tell me the adverse effects of tetracycline. Tell me the adverse effect. So first say the mnemonic. L, K, Advi. ADVI, or you can say Advani, Advi. LK Advi is PT teacher. So this is the mnemonic. This is the mnemonic. Now try to generate the full form. If you write the mnemonic, half job is done. है ना? सबसे पहले mnemonic लिखो. If you are writing the mnemonic, the half job is done. Got it? So LK Advi, ADVI, Advi is PT teacher. Say the full form. L for liver damage. K for kidney damage. Okay. A for anti-anabolic effects. D for diabetes insipidus, not mellitus, diabetes insipidus. V for vestibular toxicity. I for raised intracranial pressure. P for phototoxicity. Phototoxicity, if someone is taking tetracycline concentration is high in the blood and someone is going in the sun, so person can have rashes on the skin. That is phototoxicity. Okay, phototoxicity can be there. And 2T, one is teratogenic. It cannot be given in pregnancy. It is teratogenic for the fetus. And teeth and bone. It get deposited over the teeth and bone and form chelates with the calcium. So never given in growing children. So these are the adverse effects. This is a way you can learn. Okay, now coming on the uses. In the uses, I told you it is broad spectrum. It is effective for gram-positive cocci, gram-negative cocci, gram-positive bacilli, and gram-negative bacilli. But which one? Importantly, which one? So you have to learn tetracycline is first line drug or drug of choice for these conditions. Okay, for that also I am having a mnemonic. The mnemonic is vacuum the bedroom. Vacuum. There is only one U in vacuum the bedroom. Okay, so V stand for Vibrio cholerae. A stand for acne. You know, acne is also caused by bacteria. Vibrio cholerae causes cholera. Okay, C is chlamydia causing LGV. U is ureoplasma ureolyticum. Okay, causing UTI. M is mycoplasma pneumoniae causing pneumonia. So ureoplasma, mycoplasma, bhai, you can say. T is tularemia, which is causing the plague. Okay. B is Borrelia, causing the relapsing fever. And R is rickettsia, causing the various diseases, rickettsial diseases. Learn the name of the bacteria with the corresponding disease. Can you say the full form? What are the uses? Vacuum the bedroom. Say it again. Vacuum, VACUM, the bedroom. It's very easy. If you try to write now, it will be very easy. This is a way you can learn from. Now, V stand for Vibrio cholerae, A stand for acne, C stand for chlamydia causing LGV, U for ureoplasma, M for mycoplasma, bhai, T for tularemia causing the plague, tularemia plague. Okay, B for Borrelia. Borrelia से क्या होता है? Relapsing fever. R for rickettsia. Rickettsia से all the rickettsial rocky mounted spotted fever, epidemic typhus, endemic typhus, all will come here. So what is the summary? The summary is in front of you. People, we are done with one drug. Out of the 4, 1 is done. How many of you are learning, enjoying? We are done with tetracycline. In the similar way, we will take the remaining 3 drugs. Can we revise tetracycline quickly? So tetracycline. Why tetracycline is known as tetracycline? Because it is having 4 rings in that. What's the classification of the tetracycline? We divide the tetracycline in 3 categories: group 1, group 2, group 3. In the group 1, we are having 3 drugs: tetracycline, chlorotetracycline, oxytetracycline. In the group 2, we have two drugs, demeclocycline and limicycline. In group 3, we have doxycycline and minocycline. Okay. In the end, I will give some one-liners, which of them, like some important points for that. Okay. Now coming on the spectrum, it's a broad spectrum. Acting against all gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli. Mechanism of action, it inhibit protein synthesis, of course. It act on the 30th of the ribosome and inhibit step number 2. That is, it inhibit the A window so that new amino acid cannot come and bind. And it is bacteriostatic. It inhibit the cell division. It do not kill the bacteria. The mnemonic for the adverse effect is LK Advi, PT teacher. And the mnemonic for the uses is vacuum the bathroom. You can say the full form. This is a way you can learn, the easiest way, I think, in the world. Okay. Coming on the next thing. The next thing is the chloramphenicol. Can I come on the chloramphenicol? Let's start it. Chalo. We will start. Let's run. Chloramphenicol. Introduction. What is the important point here? Chloramphenicol, the structure. You can see the structure. Sometimes very simple, silly question comes in your MCQs and based on the structure. Chloramphenicol contain a nitrobenzene moiety. Nitrobenzene. You know what is benzene? You can see the benzene ring, the 6-carbon ring. And on that a nitro moiety is there. And because of which its antibacterial activity is there. So there is an MCQ once upon a time, long before that, the antimicrobial activity of chloramphenicol is due to what? Is it due to this group, or it is due to nitrobenzene moiety? So it is due to nitrobenzene moiety. So don't learn the complete chemical structure. I'm not interested in chemistry. I'm not teaching you chemistry. Okay, of course. But looking at the structure, you can identify in the exam. So the most important point in the structure here is the nitrobenzene. On the benzene, there is a nitro group. You can see that. So nitrobenzene moiety is important. That is important. So in the complete structure, it's a nitrobenzene. So here tetracycline में 4 rings were there. Here 1 benzene ring along with the nitro moiety is there. Okay, in the classification, no classification, only one drug, chloramphenicol. Here we were having 7 drugs. Here we are having only 1 drug. What is that drug? Chloramphenicol. Chloramphenicol is the only drug. We don't have any further drug. Coming on the spectrum, exactly same. It's exactly same. Acting against everyone. So it's exactly same. Gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli, including the miscellaneous also. Okay, so it is also broad spectrum like tetracycline. So the spectrum of tetracycline and chloramphenicol is exactly same. Okay, now coming on the mechanism of action. It inhibits step number 3. What is step number 3? What is the step number 3? It inhibit, of course, protein synthesis inhibition. But the point is that it acts on 50s ribosome, not on 30s. It is acting on the 50s ribosome and inhibit the step number 3. That is, it do not act on P window. P window is normal. It do not act on A window. A window is also normal. But inhibit the protein-protein peptide bond formation between the two. It inhibit the bond formation. No effect on P window, no effect on A window. Okay. But it inhibit the peptide bond formation between the pre-existing and the new. No peptide bond formation. It inhibit the shift of pre-existing to new. We know pre-existing shift on the new. That is P to A shift. So P to A shift को नहीं होने देगा. P window को नहीं effect करेगा, A को नहीं करेगा, लेकिन P to A shift नहीं होने देगा. So it inhibit P to A shift. So point is that this is the summary. It is inhibiting P to A shift. And it is also bacteriostatic. So this was acting on 30S, but this is acting on 50S. You get MCQ on that. Tetracycline acts on 30S. Okay. And chloramphenicol act on 50S. Okay. Tetracycline inhibits step number 2. That is, it is acting on P window and it is acting on A window and inhibit the binding of new amino acid on the A window. And this inhibit the peptide bond formation between the two and which shift? It is P to A shift. P to A shift nahi hoga. Okay. And this is also bacteriostatic and this is also bacteriostatic. Say yes if you got it. Anyone have any confusion? Okay. Now coming on the adverse effect and uses. So coming on the adverse effect. Adverse effect of chloramphenicol. There is a mnemonic. The mnemonic is big super hyper. Big super hyper. The most important and most serious side effect of chloramphenicol is bone marrow depression. You know, in humans, where are the blood cells formed? The blood cells are formed in the bone marrow. You may have read this in pathology. Huh? The blood cells are formed in the bone marrow from the first cell, the very first cell, hematopoietic stem cell. The hematopoietic stem cell give rise to RBC, WBC, platelet, all of them. Okay, now imagine if some drug like chloramphenicol, it is killing the hematopoietic stem cells. So no RBCs are formed, no WBCs are formed, no platelet are formed. So on giving chloramphenicol, the person can have pancytopenia, serious pancytopenia. Okay, serious pancytopenia. So person can be anemic because RBCs are less. Person can be leukopenic, so increased susceptibility of infections, and person can have less platelet, that is thrombocytopenia, and increased bleeding tendencies. So that is pancytopenia. That is the most serious side effect. So you know, chloramphenicol we don't prefer to give. It is not first choice of drug for anything. Okay, if other alternatives are available, we try to give that. But if alternatives are not available, or if the person or patient is resistant to the alternative drugs, then we will try. The last option is chloramphenicol. Chloramphenicol is never first choice of drug because of this side effect. This is also your MCQ, because it is a very serious side effect. Now, for treating an infection for which other drugs are also available, if we are giving chloramphenicol and taking risk for pancytopenia, it is not worthy, I guess. Okay, so B for bone marrow depression. Okay, I is for irritative effect. If you give orally, person have diarrhea, person have nausea. If you give injection, the person have pain at the injection site. So irritative effect locally, whatever route you are giving. So irritative, I for irritative effect like nausea, vomiting, diarrhea, pain on the injection, like that. G for gray baby syndrome. Gray baby syndrome is also a very important MCQ, you know. So never give chloramphenicol to a newborn baby. So if you are giving chloramphenicol to sometime now baby can have eye infection, and chloramphenicol eye drops are available. So for to treat the eye infection in a newborn, if we are giving the chloramphenicol eye drops, now babies don't have very strong renal system, they are just newborn. Now the renal system is not very strong, so chloramphenicol can accumulate in the body and can cause cyanosis in the baby. Now because of the cyanosis, baby look bluish and gray, and that's why it is known as gray baby syndrome. So gray baby syndrome, never give chloramphenicol in a newborn. If it is given in a newborn, the baby can have cyanosis, and it is gray baby syndrome. Super is super infection, hyper is hypersensitivity. Hypersensitivity is allergy. Allergy किसी भी drug की हो सकती है. So this is what you have to learn. Okay, this is what you have to learn. Adverse effect. And finally, uses. As I told you, it is highly restricted because of the fear of fatal toxicity, bone marrow depression, bone marrow toxicity, bone marrow depression, the fatal, sometimes it can be fatal. So we don't give it. We give it only if other drugs are not working in these 6 conditions. Okay, but here also it is not first choice. We try other drugs. If it is not working, then we give this. So the mnemonic is Bayer TB. So B stands for bacterial meningitis or pyogenic meningitis, not a first choice. We try other drugs. If it is not working, then we give. So bacterial meningitis. A for anaerobic infection. R for rickettsial infection. For rickettsial infection, the first choice is tetracycline. If tetracycline is not working, okay, we can give this. Okay, vacuum the bedroom. Bedroom ka R was rickettsial infection there. E is ear and eye infection. T is for typhoid and B for brucella. So please learn the mnemonic. Bayer TB. So what we have learned this. So first you tell me the chloramphenicol adverse effect and uses. What I am asking? Chloramphenicol adverse effect and uses. Can we revise? What are the adverse effect? The adverse effect is big, B-I-G, big, super hyper, very easy. And uses, Bayer TB. B-A-R-E, Bayer TB. You can make some other mnemonic if you wish. Okay, so here B is bone marrow toxicity and G is gray baby syndrome. Only 2 are important, others are not important. If you want to learn all, it's okay, but 2 are important: bone marrow toxicity and gray baby syndrome. I for irritative effect, S for super infection, and I for hypersensitivity, that is allergy. And here B for bacterial meningitis, A for anaerobic reaction, okay, anaerobic infection, R for rickettsial infection, E is ear and eye infection. Okay, T for typhoid, B for brucella. So that is Bayer TB. Got it? Can we go ahead? Got it? Yes. So it is never first choice. So the same thing is given in front of you. We are done. So compare the structure of both of them. Here we have classification. Here we don't have classification. Spectrum of both of them is same. Tetracycline and chloramphenicol, both of them are broad spectrum. The most important, compare their mechanism of action. Tetracycline act on 30S of the ribosome. Chloramphenicol act on 50S. This was inhibiting step number 2, that is A window. This was inhibiting step number 3, that is P2A shift. And this is also bacteriostatic. This is also bacteriostatic. Now see the adverse effect and uses. Here LK Advani is a PT teacher. Here big super hyper. Here vacuum the bedroom. Here Bayer TB. So try to say the full forms. Now coming on the third protein synthesis inhibitor. So the third protein synthesis inhibitor is aminoglycoside. Are you people still with me? Give me a thumbs up. Can we go ahead? So let's start aminoglycoside. The third one is the aminoglycoside. Aminoglycoside. Why aminoglycoside is known as aminoglycoside? Because here the amine groups are glycosidically linked with the amino sugars. So here the amine groups are linked with the amino sugars glycosidically. That's why known as aminoglycoside. That is the structure. Okay. So amine groups are linked with the sugars glycosidically. Aminoglycosides. That is the structure. Broadly, you see the structure. Don't learn them. Now coming on the classification. None of the aminoglycoside is given orally. They don't come in the form of the tablets. No, they are given either injections, that is systemic aminoglycosides, or they are topical in the form of the ointment. They are topical in the form of the ointment and the eye drops. Okay, so they can be topical. They can be topical. Got it? So they can be topical. So they can be systemic and they can be topical. Got my point? That is aminoglycoside. Okay. So in the systemic, how many amino? In the topical, we have only two. The mnemonic you can learn is NF or FN. That is neomycin and pharmacin. Neomycin and pharmacin, only two are there. But here we are having 8. 8 plus 2, total 10 are there. 8 of them are systemic and 2 of them are topical. Which 8 are systemic? The mnemonic is TANGS. TANGSS. TANGS KP. TANGSS. TANGS KP. You can see TANGS KP. So here T stand for tobramycin. A stand for amikacin. N stand for netlimycin, not neomycin. Neomycin is topical one. G stand for gentamicin. Double S, there are two S. One is streptomycin, one S, and one is cesomycin. Okay, K is kanamycin and P is paramomycin. So you can learn TANGS KP. So total 8 plus 2, total 10 are there. So sometime you get question which of following is systemic aminoglycoside and which of the following is topical aminoglycoside. None of them is oral. Learn the classifications. You have to learn the classifications. There is no choice. So in the systemic, we are having 8. In the topical, we are having 2. Total 10 are there. How many are there in the systemic? Can you say? The mnemonic is TANGS. TANGSS. TANGS KP. You can make some other mnemonic and share with me also. So I can share with everyone if you have some better version. And in the topical, you have 2 NF. This is neomycin and pharmacin. Very easy. And here it is tobramycin, amikacin, netlimycin, gentamicin, streptomycin, cesomycin, kanamycin, paramomycin. Like that. All of them are mycin. The suffix is same. Now coming on the spectrum. Spectrum is narrow. It is not broad spectrum. It is narrow spectrum. It is effective only against gram-negative bacilli. Gram-negative bacilli. That's it. So it is effective only against gram-negative aerobic bacilli. Very specific. Not against cocci. None of the cocci. Neither gram-positive cocci nor gram-negative cocci. So never give aminoglycoside to treat cocci. None of the cocci it is effective. It is effective only against bacilli. In the bacilli also it's only gram-negative bacilli, not gram-positive bacilli. Very specific. It's very specific. And that too aerobic gram-negative bacilli. Aerobic gram-negative bacilli. It's very specific spectrum. Okay, mechanism of action. It inhibits step number 1. Absolutely right. It inhibits step number 1. So what is step number 1? Initiation. Because it inhibits the P window. No P window, no initiation. The first amino acid cannot come and bind. So it inhibits initiation. Now where does it act? 30S also, 50S also, and their junction also. So please see. Tetracycline was inhibiting 30S. Chloramphenicol was inhibiting 50S. But aminoglycoside is inhibiting 30S as well as 50S as well as their junction. Very specific. Very specific. You get many MCQs over here. Please highlight it and learn it permanently. Okay. Now, the tetracycline is bacteriostatic. It don't kill the bacteria. It is just static. And this one is chloramphenicol is also static. But aminoglycoside is both bacteriostatic as well as bactericidal. Now, which step they are inhibiting? This was inhibiting step number 2 because it is inhibiting A window. This was inhibiting step number 3 because it was inhibiting P to A shift. And this is inhibiting step number 1, that is inhibiting the step number it is inhibiting P window, that is the first step. Okay, so that is the thing. So it is bacteriostatic as well as bactericidal. What are the adverse effects? The adverse effect, the mnemonic is on HT. So it can be autotoxic, it can be nephrotoxic, it can be neuromuscular blocker. Autotoxic, nephrotoxic, neuromuscular blocker. H is hypersensitivity and T is teratogenic. So this is also teratogenic like tetracyclines. Okay, so please learn. So what is the mnemonic here? Can you say the mnemonic? On HT. Autotoxic, nephrotoxic. So it is toxic on the ear. Let me draw the ear over here. Hana? It is toxic over the kidneys also. So it is autotoxic, it is nephrotoxic, it is neuromuscular blocker. So these are the nerves. It is neuromuscular blocker. है ना, न्यूरोमस्कुलर ब्लॉकर. इट इज हाइपर सेंसिटिव तो सभी का होता है. टी फॉर टेराटोजेनिक. ओके, व्हाट आर द यूजेस? द यूजेस आर ओनली ग्राम नेगेटिव बेसिली. The infections caused by gram-negative. So what are the infections caused by gram-negative bacilli? All the infections caused by gram-negative bacilli like UTI, meningitis, pneumonia, peritonitis, burns, osteomyelitis, sepsis we can use. We can use that in TB also. Okay, we can use that in TB also. In the TB, streptomycin, kanamycin can be used. Okay, as anti-tubercular drugs. We can use in parasitic amoebiasis also. In the amoeba, the parasitic infection. And we can use in the topical infection like neomycin and pharmacin. Okay, so that is the thing. So these are the uses. So basically uses is all gram-negative bacilli तो है ही है. उसके अलावा TB, उसके अलावा amoeba, and उसके अलावा topical. You have to learn that. And apart from that, all gram-negative bacilli. Okay, that is the uses. Coming on the last one, erythromycin. So this will be done. Can we come? The last one, erythromycin. Say. So let's come on the last one, erythromycin. Erythromycin is one of the macrolide. It is one. There are many macrolide. Erythromycin is the prototype among them. Macrolide. Why macrolide antibiotics are known as macrolide? What do you mean by macro? Macro means big in size. Anything big in size is known as macro. Got it? Anything very big in size. So here, see the size of the ring. It's having a macro ring. Just a second. It is having a very macro size ring. So macrolide have macrocyclic lactone ring with attached sugars. That is why it is known as macrolide. So here it is a big ring with many sugars attached to that. Classification wise, how many drugs are there? You can see these all are the drugs. Classification wise, just a second. So how many drugs we have? We have 5 drugs. Erythromycin, roxithromycin, clarithromycin, azithromycin, and spiramycin. So can we make some mnemonic? We can make a mnemonic C-A-R, car, S-E, C-car, C, or E-S, E-S, C-A-R. We can make a mnemonic. These are the 5 type of macrolides. So what are they? What are they? It can be erythromycin, it can be spiramycin, it can be clarithromycin, azithromycin, or roxithromycin. Nowadays, tacrolimus is also included here in this category. Okay, you can make T also, Setcar, tacrolimus. But tacrolimus is not an antibiotic. It do not kill the bacteria. It is an immunosuppressant drug. So the category is different. You know, the classification wise, the structure wise, it is also a macrolide, but it is not an antibiotic. So say how many macrolide antibiotics you know? Macrolide, how many you know? So you can make a mnemonic SET, set car. Okay, so it can be spiramycin, erythromycin, tacrolimus, clarithromycin, azithromycin, roxithromycin. So here the prototype drug is erythromycin. We can take the erythromycin. So learn the classification very well. Now what is the spectrum? Now see, everyone on the screen. Please focus on the screen. I want everyone on the screen. What was the spectrum of the tetracycline? Say ma'am, it is broad spectrum. Since it is broad spectrum, it is effective against all 4. Gram positive cocci, gram negative cocci, gram positive bacilli, gram negative bacilli. It is effective against all 4. Okay, spectrum wise. Chloramphenicol is also effective against all 4. It is also effective against all 4. But what was aminoglycoside? Aminoglycoside was effective against only gram negative bacilli. Only against gram negative bacilli. So the remaining 3 are feeling bad. Learn like a story. The remaining 3 are feeling bad. That is gram positive cocci, gram negative cocci, and gram positive bacilli. So they will come here. So the whatever is left, they will come here. So here the spectrum is all bacteria except gram negative bacilli. So the remaining 3 will come here. Here all 4 are there. Here all 4 are there. Here only gram negative bacilli. Here remaining 3 except gram negative bacilli. I hope you are learning it well. If you learn them in a sequence, it will be very easy for you to learn. Okay, mechanism of action, it is inhibiting the last step, step number 4, that is translocation. Step number 4, that is translocation, that is A to P shift. So it is inhibiting the last step, that is translocation, that is A to P shift. So it is acting on the 50S and it is inhibiting A to P shift and it is also bacteriostatic. Now compare tetracycline inhibit 50S, chloramphenicol inhibit, tetracycline inhibit 30S, chloramphenicol inhibit 50S, erythromycin also inhibit 50S, but aminoglycoside inhibit 30S, 50S and the junction. Now which step they are inhibiting, you know. All of them are bacteriostatic except aminoglycoside, which is bacteriostatic as well as bactericidal. You get question on that. Okay, coming on the adverse effect and uses. Last, so adverse effect of erythromycin, adverse effect of macrolide, the mnemonic is macro. The adverse effect is of macrolides only. So macrolide ka mnemonic is macro. So M stand for motilin receptors. These are the motilin receptors agonist. What are motilin receptors? Motilin receptors are present in the GIT, human GIT. It is present in all of us. So they stimulate. If I am taking the erythromycin, it will stimulate the motilin receptor and that will cause the parasymptolysis. So person can have diarrhea. So that can be a side effect. Okay, motilin receptor agonist. Number 1. A for allergy. A for allergy. Okay. Allergy or hypersensitivity is in all of them. C is for cholestasis. Cholestasis is jaundice. Okay, cholestasis and reversible autotoxicity. Here also autotoxicity is there like aminoglycoside, but an aminoglycoside it was irreversible. Here it is reversible. It is reversible. It is reversible autotoxicity. That is RO, reversible autotoxicity. Got it? That is reversible autotoxicity. That is the adverse effect. Okay, that is the adverse effect. Now coming on the uses. The uses is claw, C-L-A-W, claw. The uses is claw. Okay, C stand for chancroid. That is an STD caused by Haemophilus ducrei or Corynebacterium diphtheria or Campylobacter. 3 C are there. L for Legionella, A for atypical pneumonia, W for whooping cough caused by Bordetella. Learn the 3 C. Chancroid, Corynebacterium diphtheria, Campylobacter. Learn the C3. So we are done. We are done. So you can see macro and claw. I hope it's very clear. Most of the time question comes on mechanism of action and spectrum. Question comes either on spectrum or mechanism of action or uses and adverse effect. Most of the time, question comes on uses and adverse effect. I hope you can do the questions. Say yes, no, say something. Can we solve some questions? Your previous year question of various exam based on this topic. We are done with the first topic, the protein synthesis inhibitor. Protein synthesis inhibitors. I taught you 4 drugs here. So the first question is in front of you. Read the question and tell me the answer quickly. Can you read the question and tell me the answer, please? Can you read the question and tell me the answer, please? What is the mechanism of action of tetracycline? Tetracycline inhibit protein synthesis by which mechanism? Read the 4 option and you tell me the answer, please. Is it inhibiting initiation and causing misreading of mRNA? Is it binding to 30S subunit and inhibit binding of amino acyl tRNA? Or is it inhibiting peptide transferase activity, that is peptide bond formation? Or is it inhibiting translocation? So I guess this is step number 4. I guess this is step number 3. I guess this is step number 2 and this is step number 1. Initiation is step number. So which step it is inhibiting? You tell me. Yes, you all are right. Absolutely right. Vipresh, Rimsha, Fatima, Punit, Dr. Varun, everyone is right. Yes, step number 2. That is, it inhibit the 30S. We know that. And it inhibit the binding of new amino acyl tRNA on the A window. It acts on the A window. So step number 2 is inhibited. That is B is the answer. So if I keep on changing the question, you will keep on changing the answer. If instead of tetracycline, I ask you aminoglycoside, your answer will become A. If instead of that, if I ask you chloramphenicol, your answer will become C. Peptide bond formation inhibition. And if I change my question to one of the macrolide, that is azithromycin or erythromycin or clarithromycin, your answer will become D. So the question is very common. Don't learn only this question, learn all 4 questions. Okay, in this one question 4 questions are hidden. So very frequently you get the question on this, the mechanism of action of the protein synthesis inhibitor, the exact step. So these are the 4 steps. Okay, different antibiotic are inhibiting one of them. Okay, which of the following is a side effect of streptomycin? Now it's a double step question. First of all, you tell me what is streptomycin, which category drug it belongs to, and then you tell me its side effect. First you tell me the mnemonic of the side effect, then we can solve. So what is streptomycin? Say ma'am, streptomycin is one of the aminoglycoside. It is one of the aminoglycoside. It is one of the aminoglycoside. Okay, streptomycin. I told you total 10 aminoglycosides are there. Yes or no? Total 10. 8 of them are systemic and 2 of them are topical. The 8 systemic, I told you the mnemonic is TANGS. TANGSS. TANGS KP. So one of the S is streptomycin, one is cizomycin. So streptomycin is one of the systemic aminoglycoside. So what is the mnemonic for its side effect? The mnemonic is on HT. I told you the mnemonic now. On HT. Apply the mnemonic. Now see what is coming here. What is the side effect? Is phototoxicity coming in this mnemonic? I don't think so. Hepatotoxicity coming? No. H for hypersensitivity? No. Is autotoxicity coming? Yes. So the correct answer is C. This is how you can approach the question if you know. No, it's not D. It's not D. Okay. The correct answer here is C. I hope you got it. So if you know the mnemonic, you can apply it well. Okay. The mnemonic is on HT. On HT. I told you the mnemonic very clearly. Learn all the mnemonics. The mnemonic should be very clear in your mind. If you write the mnemonic, half job is done. Now let me change the question. Instead of streptomycin, let me ask the same question for tetracycline. Tetracycline. The options are same. Change your answer. Tetracycline. Apply the mnemonic. What is the mnemonic for side effect of tetracycline? Say ma'am, L.K. Advani PT teacher. So L.K. Advi or Advani. PT teacher. Now see the option. Is phototoxicity coming here? Say yes ma'am, it's coming. Is hepatotoxicity coming? Yes, it is liver. It damaged liver. But is it autotoxicity coming? No, so autotoxicity is not there. So I will go with option A and B. Not C, not D. A and B. Okay, A and B will be the correct answer in that case. So I mean, if you know the mnemonic, things are super simple. How to apply that, that's more important. That's more important. I hope you got it. So the next question is in front of you. It's a repeat question. Okay. The next question is in front of you. Tetracycline inhibit protein synthesis by acting on which fragment of ribosome? Does it act on 30S? Does it act on 50S? Does it act on both 30S or 50S? Or does it act on 60S ribosome? You tell me. Tetracycline I am asking. So I taught you 4 drugs. If you don't change the sequence, the things are simple. Tetracycline, chloramphenicol, aminoglycoside, and macrolides. So I taught you very clearly this act on 30S, this act on 50S, this also act on 50S, but aminoglycoside act on 30 also, 50 also, and 30-50 junction also. So currently they are asking the question based on tetracycline. So my answer is very clear. The answer is 30S. But if I change the question from tetracycline to chloramphenicol or to erythromycin, in both these cases, my answer will become 50. But if I change the question to one of the aminoglycoside, okay, any of the mycin, gentamicin, streptomycin, one of the aminoglycoside, my answer will become C. So the questions can be any. Okay, the questions can be any. Got my point? Can we go ahead? Can we go ahead? Okay, coming on the next question. The next question is gray baby syndrome is caused by. I guess very easy question. Gray baby syndrome. The four options are penicillin, chloramphenicol, rifamycin, and erythromycin. Rifampicin or erythromycin. So gray baby syndrome. You remember the mnemonic big super hyper. Big super hyper. It is a mnemonic of which antibiotic? So it is a mnemonic of chloramphenicol. What is G here? The B is bone marrow toxicity and G is gray baby syndrome. So of course it is caused by chloramphenicol. Be fast in answering. So the mnemonics are very simple. If you know the mnemonic, you can answer any of these MCQ. Please believe me. The master chart is important. So please learn the master chart. Which of the following aminoglycoside is not available for parenteral use? So the question is based on the classification of the aminoglycosides. How many aminoglycosides we have? There are total 10 aminoglycosides. Okay, 8 of them are systemic and 2 of them are used for topical. So they are systemic means parenteral. Systemic means parenteral. So they are asking which of the following is not systemic. So here we have 8. Which 8? Tangs. TANGSS. Tangs KP. These 8. And 2 topical is neomycin and framycin. So the answer will be from these. No? Neomycin. These are topical. These are not systemic. The remaining. So you can see cizamycin is coming here. Okay. Amikacin. It's coming here. Okay. Gentamicin. It's coming here. But where is framycin? Framycin is not parenteral, it's topical. So the correct answer is framycin. So the questions are very simple. Okay, if you know the mnemonic. The next question, which of the following is a side effect of streptomycin? I guess we have done this question, okay. Which of the following acts on motilin receptor? Which of the following acts on motilin receptor? Erythromycin, tetracycline, norflox, or chloramphenicol. So the mnemonic macro, if you remember the mnemonic macro is a mnemonic for macrolides. The side effect of macrolides. M is motilin receptor agonist. So one of the macrolide, that is erythromycin, causes motilin receptor activation and causes the diarrhea. So correct answer is erythromycin. Okay, can we come on the next category? We are done with one of the category of the antimicrobial drug. Okay, so let's come on the next category of antimicrobial drug. Let's come on the next category of antimicrobial drug. We have already covered the antibiotics which inhibit protein synthesis. Now I am going to tell you the antibiotic which inhibit nucleic acid synthesis. I told you this is a bacteria. I want to kill this bacteria. There are 4 ways to kill this bacteria. Number 1 way, we can give the antibiotic that inhibit the cell wall. That inhibit the cell wall synthesis, number 1. Number 2, there can be the antibiotic that will cause the pores in the cell membrane so that the cytoplasm will leak out and the bacteria will die. And third, there can be the antibiotics that act on the ribosome, inhibit the ribosome, either 30S or 50S or both of them, and inhibit the protein synthesis in the bacteria. We have already seen here. So I taught you 4 antibiotics here. And now I'm telling you the antibiotics which interfere with the nucleic acid synthesis, the DNA synthesis or RNA synthesis, so that the bacteria cannot divide and the bacteria will die. Okay. So nucleic acid synthesis inhibitors. Can I start the nucleic acid synthesis inhibitors? Are you people with me? So here there are 3 categories of nucleic acid synthesis inhibitors. Here we have seen 4 categories. What are the 4 categories? Tetracycline, chloramphenicol, aminoglycosides, and erythromycin or macrolides. Here there are 3 categories. In this, there are 3 type of antibiotics are there in our syllabus. Okay. So sulfonamides are there, trimethoprim is there, and quinolones are there. First of all of them act on the nucleic acid. That is DNA, RNA. They do not touch protein. They do not act on the ribosome. They do not act on the cell wall. They do not act on the cell membrane. These 3 are nucleic acid interferers, nucleic acid inhibitors, synthesis inhibitors. Which 3? Sulfonamide, trimethoprim, and quinolones. We will take them one by one. Again, the same master chart, the same heading. Please make these master charts with me. That's a request. Okay. Chalo. So let's start the sulfonamides. Can I start the sulfonamides? So first of all, tell me the classification of sulfonamides. How many classifications, how many sulfonamides are there? What is the basis of classification? So we classify them in 5 categories. Short acting, intermediate acting, long acting. Short, intermediate, long. After that, topical, and after that, special sulfonamides. In the short acting, you have to learn the classification. I'm leaving this classification. You learn by your own, but please learn it. For example, in the short acting, there is sulfadiazine. Okay. Sulfasoxazole, sulfamethoxazole, and sulfacysteine. So sulfa is common. Learn the suffix. Learn the sulfadiazine, sulfasoxazole, sulfamethoxazole, and sulfacysteine. In intermediate, only one. It's sulfamethoxazole. Here sulfamethoxazole, here sulfamethoxazole. You have to see the differences in the option. You can identify them. In the long acting, it's sulfadoxine. This was sulfadiazine and this is sulfadoxine. You get MCQs on that. This is sulfamethizole. This is sulfamethoxazole. This was methizole. This is methoxazole. This is diazine. This is doxin. And this is sulfamethopyrazine. This is a different. You can identify. So please see them. The words are very similar. You can confuse in the diazine and doxin. You will get MCQ on that. You will get confused in the methizole and methoxazole. You will get confused and you will get an MCQ on that. So please, I have highlighted where you get the MCQ. You have to learn this classification. After the classification is over, introduction is nothing. Classification, let's come on the spectrum. Okay, before spectrum also, it's also a broad spectrum. Come on the mechanism of action. In the mechanism of action, it inhibits the nucleic acid. Nucleic acid means DNA and RNA. So it's an indirect inhibitor. Actually, out of these three, these two are indirect inhibitors of nucleic acid. What do you mean by indirect inhibitor? Now, for the synthesis of DNA or RNA, please understand, for the synthesis of DNA and RNA, we require folic acid. We require folic acid. From the folic acid only DNA and RNA are formed. Now imagine a drug who is inhibiting folic acid synthesis. So if there is no folic acid, no DNA or no RNA. So it's an indirect inhibitor. Okay, directly they do not inhibit DNA or RNA synthesis inhibitor. They inhibit folic acid synthesis inhibitor. This also and this also. But this one is a direct inhibitor. It directly inhibits DNA synthesis. Directly. These two are indirect inhibitor because indirectly they inhibit the folic acid synthesis inhibitor and because of which DNA cannot form. So these two are indirect inhibitor of nucleic acid. This one is a direct inhibitor, the first thing. Okay. Now sulfonamide is an indirect inhibitor. No? So it inhibits folic acid. How does folic acid is formed? You have to understand how does folic acid is formed. Folic acid is formed from PABA, para-aminobenzoic acid. PABA, para-aminobenzoic acid. It get converted to dihydrofolic acid and dihydrofolic acid converted to tetrahydrofolic acid. This is how folic acid is formed. The normal folic acid is tetrahydrofolic acid only. And two enzymes are required. For the first step, folate synthetase is required. And for the second step, dihydrofolate reductase is required. Two enzymes are required. Now we have two drugs. One is sulfonamide and one is trimethoprim. The two enzymes are inhibited by the two drugs. So this enzyme is inhibited by sulfonamide. This one. Okay, and this enzyme is inhibited by trimethoprim. Okay, both of them are folic acid synthesis inhibitors. So what we have learned? We have learned how does folic acid is formed. How does folic acid is formed? What is the precursor of folic acid? Folic acid is formed from PABA, para-aminobenzoic acid. Para-aminobenzoic acid converted to dihydrofolic acid and dihydrofolic acid converted to tetrahydrofolic acid. This is how folic acid is formed. But for this two enzyme is required. One here, one here. The name of the enzyme required for conversion of PABA to DHFA. Name of that enzyme is folate synthetase. And the name of the enzyme that required to convert dihydrofolic acid to tetrahydrofolic acid is dihydrofolate reductase. This is folate synthetase. This is folate reductase. Now we have two drugs. What is the first drug? Sulfonamide. Sulfonamide inhibit this. So this conversion do not take place. So folic acid is not formed. And trimethoprim inhibit this one. So this step is inhibited. So tetrahydrofolate is not formed. So best is to give them in combination. So that's why we always give sulfonamide and trimethoprim in combination. We never give them alone, or rarely we give them alone, because it's a sequential blockage. What it is known as? This is known as sequential blockage. The two enzymes are blocked one by one. So we will have a better action if we block both of them. If we are blocking only this, so maybe sometime a little bit of folic acid is formed. If we are blocking only this, again there is a possibility by some mechanism it is formed. But if we are blocking both of them, there is hardly any chance that folic acid will be formed. Okay, so we give them together and there is less chances of resistance if we give them together. So we always give sulfonamide and trimethoprim together because of the sequential blockage, and the combination is known as co-trimoxazole. Co-trimoxazole. Okay, co-trimoxazole is the combination. The combination of the two is known as co-trimoxazole. I hope you got all this clearly. Give me a thumbs up if you are getting it. Got it? Can we go ahead? That is a mechanism of action. That is co-trimoxazole. So what is co-trimoxazole? The combination of the two. Okay, trimethoprim is only one drug. We don't have further trimethoprim. Trimethoprim में एक ही drug आता है trimethoprim. But sulfonamides are many. It can be short acting, intermediate acting, long acting, special, you know. So trimethoprim is combined with which of the sulfonamide? Which of the sulfonamide? So we take sulfamethoxazole, that is intermediate acting. It's an MCQ. Sulfamethoxazole. See in the classification. In the classification, this intermediate acting. Can you see this one? Sulfamethoxazole. This one we combine with trimethoprim. Okay, because both of them have same half-life and other things. So that's why we selected this of the sulfonamide. We combined it with the trimethoprim. So sulfonamide with sulfonamide, say it completely, sulfamethoxazole. We combined it with trimethoprim and the combination is known as co-trimoxazole. So in what combination we are combining it? We are combining it in 5:1. So 5:1. 5 parts of sulfonamide and 1 part of trimethoprim. We combine them. So in a tablet, there is 5 milligram of this, 1 milligram of this, total 6 milligram. So we always take the combination of 5:1. In the ratio of 5:1, it's also an MCQ. So just suppose I am a patient and I am taking a tablet of co-trimoxazole. So what does the tablet contain? The tablet is six parts. The 5 parts are sulfonamide and 1 part is trimethoprim. The complete tablet I am taking 6-part tablet. It's just 5:1. 6 parts. So it will go inside, it will get absorbed. After absorption, it will go in my blood. But in the blood, the ratio will become 20:1 because of difference in bioavailability and volume of distribution of both of them. So after going in the blood, it will be 20:1 because some of them will go in tissue, some of them will not go in tissue. So volume of distribution will be different, but in blood, the ratio will be 20:1. So in tablet, the ratio is 5:1. After going in blood, the ratio is 20:1. So please understand your MCQ very clearly in the exam. So what I taught you co-trimoxazole. Cotrimoxazole is a combination of 2 drugs, sulfonamide plus trimethoprim. What is the ratio? Here we take them in the ratio 5:1 in tablet. After going in the blood, the ratio becomes 20:1. So please learn that. You get question here also, the combination also. With sulfonamide, we are selecting the intermediate acting. The name of the sulfonamide is sulfamethoxazole. You get all these questions. Why the ratio changes from 5:1 to 20:1 after getting absorption? Because of difference in volume of distribution. Trimethoprim have high volume of distribution and sulfonamide have low volume of distribution. So trimethoprim will go more in the tissue as compared in the blood. That's why the ratio changes to 20:1. So coming on the adverse effect. The adverse effect of both of them together, sulfonamide also and trimethoprim also. The adverse effect is ABC of rash. The mnemonic is ABC of rash. So here A stand for aplastic anemia. B stand for bilirubin displacement. You know, bilirubin bind with the albumin. Okay, bilirubin bind with the albumin so that it cannot cross BBB. It cannot cross BBB, it cannot go in the brain. So suppose this is albumin in the blood, this is albumin, and this is bilirubin binding on that. Now, if we are taking sulfonamide, if someone is taking sulfonamide get absorbed and go in the blood. So this is sulfonamide or this is co-trimoxazole. So it is having more affinity for the albumin. This is albumin. So it will displace the bilirubin from the albumin and it itself will bind with the albumin. So it will displace the bilirubin. This will come and bind here. Okay, this will come and bind here, which will sulfonamide. So sulfonamide is coming and binding with the albumin and displacing the bilirubin. So bilirubin become free. Bilirubin, so it will cross the BBB. It will cross the BBB and causes kernicterus. It will damage the basal ganglion and causes kernicterus, especially in the newborns, in the neonates. Okay, premature neonates or neonates. So bilirubin displacement, B for, and that will lead to kernicterus. I hope you got the mechanism. C for crystal urea. It will form crystals in the urine and urine can be painful. Crystal urea. Okay, R for rash or hypersensitivity. A for acetylation. It's not a side effect. You can say the way of metabolism. The metabolism, it get metabolized by acetylation. S for SLE. It causes SLE like reaction, the butterfly rash or like that. And H for hemolysis and G6PD deficiency. So ABC of rash. That is the mnemonic. What is the mnemonic of sulfonamide? Sulfonamide. I taught you sulfonamide. So tell me the mnemonic of its adverse effect. The mnemonic of its adverse effect is ABC of RASH, rash. So what is the full form? What is A? What is A here? Aplastic anemia. Okay, I will write it again. ABC rash. I'm sorry. So A for aplastic anemia, B for bilirubin displacement, that is kernicterus, C for crystal urea, R for rash, that is hypersensitivity. Okay, A is acetylation, S is SLE-like reaction, and H is hemolysis in G6PD deficiency. So a person who is having G6PD deficiency took a tablet of sulfonamide, the person can have severe hemolysis and hemolytic anemia. Okay, so that is the adverse effect. What are the adverse effect of trimethoprim? This is the adverse effect of sulfonamide. What are the adverse effect of trimethoprim? The adverse effect of both the drugs is different. Adverse effect of trimethoprim, the mnemonic is there is a bus New Mumbai to Kolkata. So B stand for bone marrow toxicity. It is having bone marrow toxicity like chloramphenicol, if you remember. Trimethoprim can have bone marrow toxicity, because of which it can lead to pancytopenia. You know, the RBCs, WBCs and platelets, all of them are formed in the bone marrow from the hematopoietic stem cell. So trimethoprim kill the hematopoietic stem cell. No hematopoietic stem cell, no RBC, no WBC, no platelet. So the person can have pancytopenia. Okay, N for nausea, vomiting. Okay, M for megaloblastic anemia. The person can have folate deficiency. So folate deficiency bacteria में तो होगी, human में भी होगी. If the human have, suppose I am the patient, I am having some bacteria inside me, for which you are a doctor and you have prescribed a drug, ma'am, take trimethoprim. I am taking the trimethoprim. Not alone, you are giving me a co-trimoxazole, the combination. So trimethoprim in that combination, what does it causes? It inhibits folate synthesis. In whom? In the bacteria present inside me. Not only in the bacteria present inside me, it will cause folic acid deficiency in me also. So the bacteria will not get the folate, bacteria will die. But because the DNA will not form in the bacteria, but folate synthesis in me, I will have megaloblastic anemia. So megaloblastic anemia can be there. T stand for teratogenic. It is teratogenic. T for teratogenic. K for potassium, kalemia. K for K, hyperkalemia. It can cause hyperkalemia. So the mnemonic bus, New Mumbai to Kolkata, you can learn. Okay, so learn the two adverse effect, and the uses of both of them is same, because we never give them alone, we give them in combination. What is the brand name of the combination? The combination sulfonamide plus trimethoprim. What is the combination known as? The combination known as co-trimoxazole. This is the combination. What is the brand name? It is available by the brand name Septron in the market. Like the paracetamol is available with the brand name Crocin. Crocin यानी क्या? Paracetamol. In the same way, Septron माने क्या? Septron matlab it contains co-trimoxazole. So the brand name is Septron and the uses is also Septron. So Septron, it is available in the market with the brand name Septron. So S for STDs. We give it for STDs. Okay. E for enteritis. Okay. Caused by the E. coli, Shigella, the dysentery. Enteritis. P for Pneumocystis carinii and Pneumocystis jeruari. You know the fungus. Pneumocystis carinii and jeruari, the pneumonia caused. So STD, enteritis, pneumonia. T for typhoid. Okay. R for respiratory tract infection. A for acute UTI. A को U बना दो ज़्यादा better है. It's UTI. Okay. And N for nocardia. Can you see the full form of Septron? So this is the summary. Okay. We will revise. Don't worry. We will revise. So you can see the summary. What we have covered. What I am teaching you. I am teaching you the drugs that inhibit the nucleic acid synthesis. The nucleic acid synthesis in the bacteria. I want to kill the bacteria. So I am not causing the pores in the cell membrane. I'm not causing the cell wall synthesis inhibition. I'm not touching the ribosome. What I'm doing, what I want to do, I want to inhibit the DNA synthesis. So there are three drugs which inhibit the DNA synthesis. What are the three drugs? Sulfonamide, trimethoprim, quinolone. Out of the three, two are done. Okay. These two do not inhibit DNA directly. They inhibit DNA synthesis, but indirectly. Indirectly means these two inhibit folic acid synthesis. If there is no folic acid, no DNA will be formed. Okay, because for DNA we require folic acid. So these two are indirect inhibitor. And now I will teach you the third one, quinolones. Quinolones. Quinolone is a direct DNA inhibitor. I will tell you that. But here these two are indirect DNA inhibitors. Please understand. These two are indirect inhibitors. Okay, they inhibit folic acid synthesis. No folic acid, no DNA synthesis, like that. So out of the three, two are done. Now compare sulfonamide and trimethoprim. These two are done. Quinolones I will teach you now. So you can see sulfonamide and trimethoprim. Here we take them in a combination 5:1 in the tablet. Learn the combination in the ratio 5:1. But after taking, they get absorbed and go in the blood. In the blood, the ratio becomes 20:1. And both of them are given together because they have synergistic action. The sequential blockage or synergistic action. So here we have the classification: short acting, intermediate acting, long acting, topical, special. Here we have no classification, only trimethoprim. We give them the combination. The combination is co-trimoxazole. The brand name is the Septron. Okay, mechanism of action, it inhibits an enzyme. The name of the enzyme is folate synthetase. It also inhibits an enzyme. The name of the enzyme is folate reductase. I hope you can understand the folate synthetase and folate reductase, the two sequential enzymes in the synthesis of folic acid from PABA. Okay, adverse effects are different. Here the adverse effect is ABC rash. And here the adverse effect is bus, New Mumbai to Kolkata. Okay, and here the uses is Septron. Here also the uses is Septron. Why the uses is same? Because we give them in combination. So what is the full form of Septron? You want to see the full form? Sulfonamide, trimethoprim. Tell me their adverse effect. Here ABC rash. Here bus from where to where? New Mumbai to Kolkata. The uses in both of them is same. It's Septron. T-R-A-N. Septron. The uses in both of them is same. So let's say first uses, the full form of uses. S for STD. E for enteritis, that is diarrhea, dysentery. P for pneumonia caused by fungus, Pneumocystis carinii and jeruari. T for typhoid. R for RTI, respiratory tract infection. A for इसको U बना दो और acute UTI, and N for nocardia. So it's very easy to say the full form of septron. Okay, here A for aplastic anemia, B for bilirubin displacement, that is kernicterus, C for crystalluria, R for rash, A for acetylation, S for SLE, and H for hemolysis and G6PD deficiency. Okay, here B for bone marrow toxicity, N for nausea, M for megaloblastic anemia, T for teratogenic, and most important, hyperkalemia. If you know the mnemonic now, people, if you say it once or twice, you will learn it. And MCQs will be super simple. Please learn that. Mechanism of action, you know for each of them. Okay, now read the question and tell me the answer. Read the, yes, it will, Punit, I'm coming on the quinolones. They will inhibit DNA gyrase, yes. So which of the following is a side effect of sulfonamide? I'm asking the side effect of sulfonamide. Say the mnemonic, ABC rash. जैसे ही question आया, the mnemonic should be in your mind. It should click in your mind immediately. ABC rash. So what is coming in this mnemonic? Constipation. No, C is not constipation. It's crystalluria. Joint pain. I don't think joint pain is coming. Crystalluria. Yes, crystalluria is coming here. Hyperkalemia. No, hyperkalemia is a side effect of trimethoprim, not sulfonamide. So the correct answer is crystalluria. This is how you can approach the question if you know the mnemonic. Okay, let's come on the quinolones, the third and the last category, quinolones. So this category will also be over. So let's come on the last category, quinolones. Can I come on the quinolones? Can I start quinolones? Let's start quinolones quickly. So we divide the quinolones in four. Let's see the classification in four generation. First generation, second generation, third generation, and fourth generation. This is the classification of quinolones. Classification. So the classification is based on their spectrum, what they are killing. So first generation kill only gram positive cocci. We will keep on increasing the spectrum, like, okay. So first generation, not gram positive, I'm sorry, they kill only gram negative bacteria, gram negative, that's it. First generation, the narrowest spectrum, they kill only gram negative bacteria, and that too not all gram negative bacteria, some of the gram negative bacteria. Here only two members are there, nalidixic acid, oxanilic acid, but we don't use them nowadays. They are outdated. Okay, we don't use them. The first generation. The second generation, they again kill only gram negative, but expanded all gram negative. Here they were killing gram negative bacteria. I agree, gram negative bacteria, but they were killing only few of them. Here we have expanded the gram negative. They cover all gram negative, not gram positive. I agree, but at least all gram negative. So here we have four drugs: Norflox, Lomeflox, Ciproflox, and Oflox. So Norflox, Lomeflox, Ciproflox, Oflox. You can make some mnemonic Nalco, NLCO, Nalco. These four drugs come in the second generation: Norflox, Ciproflox, Oflox, and Lamiflox. Okay, floxacin. These are the second generation. In the third generation, we have complete gram negative. We already have gram negative, but some gram positive also. Some. So third generation is much better. So some gram positive. So how many drugs we have? We have Levoflox, Sparflox, Gatiflox, Pflox, Timaflox, Tosuflox, Moxiflox. You can make some mnemonic if you wish, or you can see the names. It is third generation. And fourth generation is the widest spectrum. The complete gram positive will be there, complete gram negative will be there, and complete anaerobes are also there. So all gram positive, all gram negative with all anaerobes. So here you have to learn the drugs, the broadest spectrum, the widest spectrum. Here we have Trovaflox, Ferroxacin, Ferroflox, Gamiflox, Pruliflox, Sitaflox, Clinaflox. So Clinaflox, Sitaflox, Pruliflox, Gamiflox, Flaroxacin, and Trovaflox. So please learn, make some mnemonic and learn. So that is the fourth generation. So can you tell me the classification? Let's try. So first generation, second generation, third generation, fourth generation. First you tell me the spectrum. Here only gram negative, and that too moderate activity. Here also gram negative, but extended activity. Here all gram negative, the extended activity with few gram positive. Okay, a moderate gram positive. Here gram negative extended activity, gram positive extended activity along with anaerobes. So the widest spectrum is present in fourth generation. So I want you to learn the drugs in each category. Please learn the drugs in each category. At least first generation, nalidixic acid and oxanilic acid, only two are there, you have to learn. Second generation, four are there, Nalco, NLCO. So it is Norflox, Lamiflox, Ciproflox, Oflox. Maximum are coming in the third generation. You have to learn that. And fourth generation, you have to learn. You get many questions on that. Okay, now mechanism of action. What does they do? Now, you know, how does the bacteria divide? What are the steps in the replication? So this is a bacteria. This is the cell wall of the bacteria. This is the nucleus of the bacteria. In the nucleus of the bacteria, this is double-stranded DNA. Okay, what is the first step? Now this bacteria want to divide into two daughter bacteria. this bacteria want to divide into two daughter bacteria. So how does it happen? So the two strands separate from each other. The first step is the two strands separate. This is leading, this is lagging. So how does it happen? The two strands separate from each other. This is known as unwinding. Normally double-stranded DNA is like this. So if we want to first separate the leading and lagging, and then the replication takes place. So the first step is unwinding. This step is known as unwinding. In unwinding, the leading and the lagging strands separate with each other. Then on the leading strand, the DNA polymerase will come, and the complementary, first the primer will be formed, the primer will attach, and then the complementary strand will be formed here also, and the complementary strand will be formed here also. So from two strands, four strands are formed. Later on, DNA polymerase will come, primer will come, we know the steps, but the first step is unwinding. So for this unwinding, I mean, what do you mean by unwinding? Which enzyme is required for unwinding? How does unwinding take place? So this is the double-stranded DNA. First is unwinding. So we require an enzyme. The name of the enzyme is DNA gyrase, who does the unwinding. So there is an enzyme. The name of the enzyme is DNA gyrase, who is doing the unwinding. DNA gyrase. Quinolones inhibit that enzyme. Quinolones inhibit this enzyme. So no DNA gyrase, no unwinding. So the double-stranded DNA will remain as double-stranded only. It will not convert into leading and lagging. So if they cannot unwind, how they can replicate? So no replication of DNA, and the bacteria will die. Bacteria cannot divide. So it inhibit, the fluoroquinolones inhibit to DNA gyrase. Can you see this is the double-stranded DNA? Can you see this is double-stranded DNA? Let me highlight here. Appreciate double-stranded DNA. So this is the DNA gyrase coming and converting them into single-stranded. So here you can see leading, here you can see lagging. Then the DNA polymerase is coming and forming the complementary strand. But this is DNA. Now imagine if DNA gyrase is inhibited, the unwinding do not take place. The unwinding will not take place and the replication will not take place. So this is the mechanism of action of fluoroquinolones. How many of you got it? This is so it is a direct inhibitor. It is not indirect inhibitor like sulfonamide and trimethoprim, where it was inhibiting the folic acid synthesis. It's a direct inhibitor. So what are the adverse effects of fluoroquinolones or quinolones? So the adverse effect, I don't have any mnemonic. The systems are affected. It's a many adverse effects are there. So in the GIT, most common adverse effect is nausea, vomiting, diarrhea. In the CNS, it is due to GABA antagonistic action. The person can have a headache, dizziness, sleep disorder, mood changes. In the bone and soft tissue, the person can have a risk for tendon rupture. There is phototoxicity, Torsades D pointers, that is prolonged QR interval, that is CVS is affected, and teratogenicity. So GIT, CVS, CNS, musculoskeletal, four main systems are affected. You can learn like that. Okay. And in the uses, it's a broad spectrum. You can see fourth generation is the broadest spectrum. It is killing all gram positive, gram negative, as well as anaerobic. So the mnemonic is 4G spectrum CT. 4G. What are the 4G? It is used in gonorrhea, gastroenteritis, gynecological infection, and gram negative infection. 4G spectrum. S for septicemia, P for prophylaxis before surgery. So if someone is going to have surgery, we can give prophylactic antibiotic like that. P for prophylaxis. E for enterocolitis. C for chancroid. T for typhoid. R for RTI. U for UTI. M for meningitis. C for conjunctivitis. T for tuberculosis. So everything is coming here. So what is the mnemonic? Say the mnemonic. 4G spectrum. 4G spectrum CT. It's like that. So you know the 4G. It is gonorrhea, it can be gynecological infection, it can be gastroenteritis, it can be gram-negative infection. As for septicemia, P for phototoxicity, E for enteritis, okay? And C for, one of the C is conjunctivitis, okay? Typhoid, RTI, UTI, meningitis. What is the C? Let me check. So this one more C is chancroid and one more T is tuberculosis. So you can learn like that. Okay, P for prophylaxis, I'm sorry. So please learn the full form. So that is the thing. We are done. We are done with this category. Also, the master chart is in front of you. Take a photo, take a snapshot. Please learn all master charts. So I taught you 7 drugs till now. So I completed these 3 drugs also. The nucleic acid synthesis inhibitor. Please learn sulfonamide and trimethoprim. These are indirect inhibitor. They inhibit the folic acid and they are given together. The combination is known as Co-trimoxazole. But the quinolones, it's a direct inhibitor. It inhibits the DNA gyrase enzyme. Learn the uses. See the mnemonic, septron, and 4G spectrum CT. Learn the adverse effect. See the mnemonics. The mnemonics are in front of you. Okay, it's a combination of many books. It is not one book I teach. Okay, it's a combination of many books. Okay, so ultimately I make my own notes to make it super simplified. Got my point? Can we go ahead? So what I taught you till now, Is there any questions? We will solve the questions, then we will revise. So the first question is in front of you. Okay. Which of the following fluoroquinolone has broadest spectrum? Broadest spectrum. Broadest spectrum means fourth generation. So we divide the fluoroquinolones in four generation. First, second, third, fourth. The fourth is the broadest spectrum. So which of the following belongs to fourth generation? So read your option. Is it ciproflox, norflox, trovaflox, or nali? Nalidixic acid. Yes? What do you say? What is the correct answer? So ciproflox belong to second generation, norflox also belong to second generation, nalidixic belong to first generation, but trovaflox belongs to fourth generation. So trovaflox is the correct answer. So please learn the fourth generation. All the fourth generation. Please, you get many questions on that. Okay, got it? Can we go ahead? Can we go ahead? So what we have learned till now? Till now, I taught you 7 drugs. I taught you the drugs that inhibit protein synthesis inhibitors, and I taught you the drugs which inhibit the nucleic acid synthesis inhibitors. Here I taught you 4 drugs: tetracycline, chloramphenicol, aminoglycoside, and macrolide or erythromycin. Here I taught you 3 drugs: sulfonamide, trimethoprim, which we give them in combination, and quinolones. Anyone have any confusion? I want each one of you should know the exact mechanism of action of each of them, on which you get maximum questions. Number 1. Number 2, adverse effect, mnemonic for each of them. I have given you mnemonic for each and every adverse effect, and uses adverse effect for each and every one of you. Everyone give me a thumbs up. I will upload the PDF. Okay? YouTube for FMG. I will upload the PDF after the session. Okay, I will hand over to the team, and the team will upload it on their Telegram channel where you are watching it right now. The same team. Okay, I will upload it. Okay, got it? So can we go ahead? You got it? Anyone having any confusion till now? Otherwise, give me a thumbs up. So we have completed 2 major portions till now. We have completed protein synthesis inhibitors, and we have completed nucleic acid synthesis inhibitors. Now the next I want to take is the anti-tubercular drugs. I will take anti-tubercular drugs now, the third category. Okay, anti-tubercular drugs. I will teach you 5 drugs here: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. That is HRZES. The 5 first line anti-tubercular drugs. The same master chart. Like this only, the master chart we will make. The master charts. Okay. So till now I have given you 2 master chart. I'm giving you the third master chart now. Okay. So anti-tubercular drugs. Are people ready? Can we start? Anti-tubercular drugs. After that, I will go on the endocrine system, and I will teach you diabetic drugs, anti-diabetic drugs, I mean. And after that, I will move to the respiratory system, and I will teach you the asthma drugs today only. So system by system, we will move. Okay. So let's come here. The anti-tubercular drugs. Give me a thumbs up. Are you people there? Are you live? Can we go ahead? Just a second. Okay, so let's start it. Anti-tubercular drug. So you know tuberculosis is caused by a bacteria. The name of the bacteria is Mycobacterium tuberculosis. To treat that Mycobacterium tuberculosis, we have a guidelines. The guidelines are known as DOTS. You know, under DOTS, we will treat the tuberculosis, the primary tuberculosis, the secondary tuberculosis. You know, what is DOTS? Directly observed short-term therapy. Okay, directly observed. Why it is directly observed? Because the treatment is given in someone's supervision, the supervision of some healthcare provider. Okay, so that is DOTS. You may have read the RNTCP program. I know in the PSM you may have read this. So this DOTS come under the RNTCP program. So what drugs we give here in the tuberculosis? So this is the classification of the drugs. So to treat the TB, there are 2 types of drugs: the first line drugs and the second line drugs. The first line drugs are 5. What are the 5 first line drugs? HRZES. H stand for isoniazid, R stand for rifampicin, Z stand for parazinamide, E stand for ethambutol, and S stand for streptomycin. So these are the first 5 first line drugs, the 5 HRZES. The 5 first line drugs. H stand for isoniazid, R stand for rifampicin, Z stand for parazinamide, E stand for ethambutol, and S stand for streptomycin. The 5 first line drugs are there. Okay, the 5 first line drugs are there. So this master table we are going to make. Okay, in the introduction I will tell you important points regarding each of them in a differentiate form. Okay, you have to differentiate them from each other. Mechanism of action of each of them and adverse effect. Why not uses? Because all of them are used in TB only. The uses TB, the first line drug of the TB. I am teaching you anti-tubercular drug only. So uses, there is no column for the uses. You have to see these 3 columns. Okay, one by one. So before starting them one by one, let me tell you something. All of them, I will tell them in a sequence. HRZES, all of them kill the bacteria. Which bacteria? Mycobacterium tuberculosis. The name of the bacteria is Mycobacterium tuberculosis, except one, which do not kill the bacteria, only inhibits its cell division. Ethambutol. Ethambutol is bacteriostatic. It do not kill Mycobacterium tuberculosis. It inhibits its cell division, but remaining all four, except ethambutol. What except ethambutol? It can be isoniazid, rifampicin, parazinamide, or streptomycin. These all kill the bacteria. They are seidel. The first thing, you get question on ethambutol, number one. Okay. Number two, there are two types of bacteria. Hana, what does the Mycobacterium tuberculosis cause? It causes the disease TB. There are two types of TB. Mostly it is pulmonary TB, 90%. And 10% it can be extrapulmonary TB. The extrapulmonary TB can be in any organ, from head to toe, it can be any organ, literally any organ. So extrapulmonary, it can be lymph node, it can be intestine, it can be genitourinary, it can be any TB. Okay, but it's rare, it's 10%, 90% is pulmonary. So for example, it's pulmonary TB, this is the lung. Okay, this is the lung. Okay, these are the cells of the lung. You can see the alveolar cells, the lining cells or cells of the lung. Okay, now here is the bacteria. The bacteria, where is the bacteria? The bacteria is present here also and inside the cells also. The bacteria is present here, the Mycobacterium tuberculosis. Now, if I'm giving any drug, some drug kill only intracellular bacteria. Some drug kill only extracellular bacteria and some drug kill both. You got my point? So bacteria is present both. It is present intracellular as well as extracellular. So which drug is killing intracellular, which is killing extracellular, which is killing both? You have to learn that. So the isoniazid kill both, intra plus extra. Okay, rifampicin also kill both, intra plus extra, and ethambutol also kill both, intra plus extra. But parazinamide kill only intracellular bacteria, intracellular Mycobacterium tuberculosis, which is present inside the cell of the lung. Okay, and streptomycin kill only extra. You get question on that. So please, you see this in a comparative manner so that it will be easy for you to learn. So first learn only ethambutol is static, rest all are seidel, and then learn all of them kill both except parazinamide and streptomycin. Parazinamide kill only intracellular, streptomycin kill only extracellular, the remaining three kill both. That is the thing. Now the first three, HRZ, don't change the sequence. The first three are hepatotoxic. They cause damage to the liver. The next two are not hepatotoxic. Maximum hepatotoxic is parazinamide. Now I will start them one by one. Are you people ready? Are you people ready? Huh? I'm teaching you anti-tubercular drugs. The first line anti-tubercular drugs. The 5 first line anti-tubercular drugs. What are the first 5 first line anti-tubercular drugs? HRZES. HRZES. So H for isoniazid, R for rifampicin, Z for parazinamide, E for ethambutol, and S for streptomycin. Streptomycin is one of the aminoglycoside. I already taught you aminoglycoside in the protein synthesis inhibitor. Okay, so these 5 first line anti-tubercular drugs we are going to understand. Now what is the main goal to give these drugs to a patient? I want to treat the patient for Mycobacterium tuberculosis. The name of the bacteria, have you read microbiology, pathology? So Mycobacterium tuberculosis is the bacteria which is causing the disease tuberculosis. So I want to kill this bacteria. Either I want to kill it or I want to inhibit its cell division. So it can be bactericidal, it can be bacteriostatic. So all of them are bactericidal. They kill the bacteria. Except ethambutol, which is bacteriostatic. It do not kill, it inhibit the bacterial growth. Rest all are bactericidal. Okay, now let me tell you the mechanism of all 5 in one diagram. In this one diagram, imagine this is a diagram. Everyone on the screen, imagine this is a diagram. This is a diagram of a bacteria. The name of the bacteria is Mycobacterium tuberculosis. This is Mycobacterium tuberculosis diagram you can see in front of you. I want to kill it with 5 drugs, HRZES. Okay, I will tell you the mechanism. Out of the 5 drugs, 3 of them inhibit the cell wall synthesis, H, Z, and E. These 3 inhibit the cell wall synthesis in the bacteria. These 3 by inhibiting different enzyme. I will tell you which enzyme. These 3. So H also inhibits cell wall synthesis, Z also inhibits cell wall synthesis, E also inhibits cell wall synthesis. No cell wall, the bacteria will burst, the bacteria will die. Okay, these three. Okay, R for R. Rifampicin inhibit ribosome. Rifampicin inhibit RNA synthesis. RNA, R for R. Rifampicin inhibit RNA synthesis. DNA to RNA conversion is inhibited. R for R. Okay, and S. The last one is S. Streptomycin. It inhibit protein synthesis. I already told you it is one of the aminoglycoside. It inhibit protein synthesis. It will inhibit the step number 1, initiation. It will bind on 30S, 50S as well as on junction. So this is the mechanism of action of all 5 at a glance in front of you. The 5 anti-tubercular drug. Please understand. So out of the 5, first of all, you must know the names of the which 5 anti-tubercular drugs. It's H, R, Z, E, S we are talking about, the 5 antitubercular drugs. This is isoniazid, this is rifampicin, this is pyrazinamide, this is ethambutol, this is streptomycin. This inhibit the cell wall, this inhibit the cell wall, this inhibit the cell wall synthesis in the bacteria. We are talking about the bacteria Mycobacterium tuberculosis. So here is cell wall synthesis inhibition in these 3. But the enzyme will be different. I will tell you which step, which enzyme. R for R. Rifampicin inhibit RNA synthesis in the bacteria. Mycobacterium tuberculosis cannot synthesize RNA, so it will die. And this inhibit the protein synthesis in the bacteria. The Mycobacterium tuberculosis cannot synthesize the protein because it inhibits the ribosome, so it will die. So the mechanism of action is like this. I hope you got it. Now, this is the bacteria Mycobacterium tuberculosis and this is the cell wall. It's a special bacteria. Which bacteria we are talking? We are talking about a bacteria Mycobacterium tuberculosis. Have you read microbiology? In the microbiology, you have seen the structure of the cell wall of this bacteria. It contains a special lipid inside that. The name of that lipid is mycolic acid. So the cell wall contains mycolic acid. Actually, the cell wall of Mycobacterium tuberculosis contain two things. Number 1, mycolic acid, and number 2, arabinogalactan. With these 2 things, the cell wall is synthesized. If both of them are present, the cell wall will be there. We are talking about the cell wall of the bacteria. The cell wall contains 2 things. Number 1, mycolic acid, and number 2, arabinogalactan. If both of them are present, then cell wall is normal. But how these 2 things are synthesized? For synthesizing mycolic acid, we require 2 enzymes. Fatty acid synthetase 1, fatty acid synthetase 2. And because of these 2 enzymes, mycolic acid is synthesized. Okay. And for synthesizing arabinogalactan, we require only 1 enzyme. The name of the enzyme is arabinosyl transferase. Arabinosyl transferase. With this enzyme, arabinogalactan is there. So if all 3, can you see the yellow color enzymes? I have highlighted with yellow colors. Can you see the 3 yellow color enzyme? Can you see the yellow color enzyme? FAST1. What is FAST? Fatty acid synthetase. FAST1, FAST2. Fatty acid synthetase 1, fatty acid synthetase 2, and arabinogalactan transferase, AT. These 3 enzymes are present, so cell wall will be normal. Now imagine the 3 drugs. Imagine my first drug. The name of my first drug is isoniazid. Isoniazid inhibit FAST2. It inhibit FAST2. Isoniazid inhibit FAST2. So no FAST2, no mycolic acid will be formed because this step is inhibited. Mycolic acid is not formed, cell wall will be not formed. Okay, HRZ. Now coming on Z. Pyrazinamide inhibit FAST1. Parasympathomimetics inhibit FAST1. So no FAST1. Here FAST2 is normal, but FAST1 is not there. So this step is inhibited. Ultimately, again, mycolic acid is not formed. Mycolic acid is not formed. Cell wall is not formed. Okay, and ethambutol inhibit arabinosyl transferase. So here mycolic acid is formed, but arabinogalactan is not formed. So ultimately, the cell wall is not formed. This is the mechanism of action of 3 out of 5, the 3 antitubercular drugs. H, Z, and E. How many of you got it? So the same thing is written in front of you in this table. You can see H inhibit. You can see H inhibits cell wall synthesis by inhibiting FAST2. Okay, FAST2 enzyme. Z inhibits cell wall synthesis by inhibiting FAST1 enzyme. And E also inhibits cell wall synthesis, but by inhibiting arabinosyl transferase enzyme. Give me a thumbs up, people. Are you live or not live? Give me a thumbs up. Appreciate the efforts. I'm super simplifying the pharmacology for you. Okay. Can you see this? So this is how the cell wall synthesis inhibition takes place. Okay, now what about R? R for R. Rifampicin inhibit RNA synthesis, as I told you. How RNA is formed? The RNA is formed from DNA. Have a look on DNA. Can you see the DNA of Mycobacterium tuberculosis? This is Mycobacterium tuberculosis bacteria. Can you see the Mycobacterium tuberculosis? Yes, you all can see the Mycobacterium tuberculosis. This is this one. Now, can you see the DNA? Here you can see the double-stranded DNA, which got unwinded. One is leading strand, one is lagging strand. From the leading strand, the DNA converted to mRNA. I mean, the complementary mRNA is formed. For this conversion, DNA to mRNA, an enzyme is required. What is the name of that enzyme? The name of that enzyme is DNA-dependent RNA polymerase. DNA-dependent, because it is forming from DNA. DNA ka leading strand. DNA-dependent RNA polymerase. It's an enzyme which is forming the RNA from the DNA. So DNA to RNA conversion enzyme, DNA dependent RNA polymerase, this enzyme is inhibited by rifampicin. So rifampicin inhibit an enzyme. The name of the enzyme is DNA dependent RNA. Don't do reverse. It is not RNA dependent DNA polymerase. No, it is DNA dependent RNA polymerase. So please understand, because here the RNA is formed. It's RNA polymerase. It is formed from DNA. So DNA dependent RNA polymerase. So this enzyme is inhibited. So because DNA dependent RNA polymerase enzyme is inhibited, so RNA is not formed. Since RNA is not formed, the bacteria will die. And lastly, streptomycin inhibit protein synthesis by inhibiting the which window? Inhibiting P window. P window means initiation will not there. No initiation, P window is inhibited, initiation is not there, step number 1 is not there, and protein synthesis will not there. So it is streptomycin. So this is the mechanism of action of all 5 together. I hope it's crystal clear. Only one of them is static. It do not kill the bacteria. It inhibits the cell division. That is a thiambutol. Never forget, you get many MCQs, repeated MCQ. Remaining all of them are civil. So I hope you got it very clearly. Now one by one I will take it and tell you the details. So I will take them in a sequence H, R, Z, E, S, and we will make a comparative table between them. You already know. What you already know till now? Siddle, static, siddle. This is you already know. Okay. The second thing, the mechanism of action of each of them. Cell wall synthesis inhibition, cell wall synthesis, cell wall. Okay. Cell wall maybe this is fast 2 inhibition. This is fast 1 inhibition, fatty acyl synthetase, fast. And this is arabinosyl transferase inhibition. This one RNA synthesis inhibition. R for R, rifampicin is RNA. The name of the enzyme is DNA dependent RNA polymerase. And here protein synthesis inhibition. Protein synthesis inhibition, the step number 1, that is P window is inhibited, no initiation. Step number 1 is inhibited. This already we know till now. Now let's continue it. Let's continue. Let me start with the first one, H. Isoniazid. You people are ready to go. So let's start with isoniazid. I already told you one thing, it kill both intracellular as well as extracellular bacteria. Okay, it is the drug of choice for TB, for the treatment of TB, and it is a drug of choice for the prophylaxis of TB also. So imagine someone is having TB and someone is in close contact with the patient. So to the close contact, to prevent the TB, we can give isoniazid. And for the treatment also we can give. Suppose a newborn is having TB, okay, a neonate or child is having TB and mother is in close contact with that, or the mother is having the TB and the newborn is in close contact with the mother. So we will give prophylaxis to the newborn like that. So it is a drug of choice for the treatment as well as for the prophylaxis. Drug of choice for treatment, drug of choice for prophylaxis. It is the drug among the 5 drug HRZDs. It is the drug which make the patient non-infectious earliest. So why we want to make the patient non-infectious earliest? Imagine this is a patient and the patient is having pulmonary TB. The patient is having pulmonary TB. So what is the most common symptom of the pulmonary TB? Patient cough. When the patient is coughing in the aerosols. In the aerosol, the bacteria is emitted out, and this will cause infection in other human beings. So other human beings who are in close contact because of this aerosol, other can also have the TB. We do not want this. So we want to cure the patient, but first target is to make the patient non-infectious so that patient don't have the cough. And in the cough, at least this aerosol do not contain the Mycobacterium TB. So although the bacteria is present inside the person, we will cure it. Patient is not cured. Cured means zero bacteria. Patient is not cured. The patient is having the bacteria inside that. Patient is not cured, but patient is non-infectious. So it is the isoniazid. So our first goal is to make the patient non-infectious. भाई इसको तो TB हो गया संभाल लेंगे, ट्रीट कर लेंगे, लेकिन दूसरों को ना हो तो इसको non-infectious बनाओ, नहीं तो इसमें से दूसरों को फैलेगा. So our first goal is to make this person non-infectious. So which drug does it earliest? It is isoniazid. It is also your MCQ. So please learn 3 important things for isoniazid. It is the drug of choice for treatment of TB, drug of choice for the prophylaxis of TB, and it is the drug which makes the person non-infectious earliest among the 5. Okay, and it kills intracellular as well as extracellular bacteria both. I guess you got the meaning of intracellular, extracellular. I told you, I'm telling you once again. So imagine these are the lungs. Mostly TB is pulmonary TB. 90% it is pulmonary, 10% it can be extrapulmonary. Now this is lungs. These are the cells of the lung. You can say alveolar cells, the lining of the alveolar cells. Okay, these are the cells of the lung. Where is bacteria? Mycobacterium tuberculosis is where? It is causing pulmonary TB now. It is present inside the cell as well as outside the cell. It is present inside the cell as well as outside the cell. So there are certain drugs which kill both, like isoniazid. Isoniazid kill intracellular as well as extracellular both. Okay, rifampicin also kill both, but parasympatholytics kills only intracellular. So you have to learn which drug is killing which bacteria. So for isoniazid, it is killing both intra as well as extra. So these are the important points. Mechanism of action, you already know it inhibits FAST2. Since it inhibits FAST2, mycolic acid will not form. Mycolic acid will not form, cell wall will not form. Coming on the adverse effect. Adverse effect, I told you, first 3 drugs are hepatotoxic. Among the 5, H, R, Z, E, S, the first 3 are hepatotoxic. Maximum hepatotoxic is paracetamide. These 2 are not. So one of the side effect is hepatitis. It is hepatotoxic. One of the side effect is allergy. Always allergy. One of the side effect is it is hepatotoxic. Okay. One of them is peripheral neuritis. Because it interferes with the production of pyridoxal phosphate. So paradoxin is absent. Paradoxin is absent. Okay. Since paradoxin is absent, it causes peripheral neuritis. So peripheral neuritis. So whenever we give isoniazid, we give a supplement of paradoxin. We always give so. So that is the thing. So peripheral neuritis it causes. And one is hemolysis and G6PD deficiency. So learn these three extra apart from allergy. Allergy to sabhi mein teen cheezein extra. One is hepatitis, one is peripheral neuritis, and one is G6PD deficiency patient mein hemolysis. Learn three side effects. Coming on rifampicin, we are done. In the end, I will show you the table. H is done. Now R, Z, E, S. So H is done. We are coming on R. Quickly, R. So R is also bactericidal. It also kills intracellular as well as extracellular like the H only. Okay. It is most potent among the five. It is the most potent drug among the five. Most potent sterilizing drug. It is not earliest, but most potent. Earliest is H. Okay. You are understanding the difference. H, R, Z, E, S. This one is Sidal. This one is also Sidal. Okay. This one kill intra as well as extra bacteria. This one also kill intra as well as extracellular. But this one is earliest to make the patient non-infectious. But this one is the most potent among the five to sterilize the patient. This is drug of choice for treatment and drug of choice for prophylaxis. Drug of choice for treatment, drug of choice for prophylaxis. This is not drug of choice. So please see the differences. Please see. Okay. So this is the thing. Okay. So this is the fastest to kill the bacteria. That's why it is the most potent. You have MCQs on all of them. Okay. Yes. On orange urine, I'm coming on that. Punit. Okay. So mechanism of action, you already know. It inhibits an enzyme. The name of the enzyme is DNA dependent RNA polymerase. This is the name of the enzyme. DNA dependent RNA polymerase. This enzyme is inhibited. So RNA will not form. RNA will not form. So bacteria will die. Okay. So from DNA, RNA will not form. So you can see this is the bacteria, the Mycobacterium tuberculosis. This is the nucleus of the bacteria. Inside the nucleus, this is the double-stranded DNA, which is unwinded, opened, unwinded. Now this is leading strand. This is lagging strand. On the leading strand, the DNA, from the DNA, the complementary mRNA is formed. From the DNA, you can see this is the DNA, the leading strand DNA. From that, the complementary mRNA is formed. And for this, an enzyme is required. For this conversion, an enzyme is required. What enzyme? The name of the enzyme, you can see it is DNA dependent. DNA dependent RNA polymerase. RNA polymerase, because RNA is formed. RNA is formed from DNA. So DNA dependent RNA. So this enzyme is inhibited. So this conversion do not take place. So RNA will not form. RNA will not form. So bacteria will die. Okay, that is the mechanism of action. It's very easy to learn. Okay, adverse effect hypersensitivity to hey, it is hepatitis. I told you the first three are hepatitis, hepatotoxic, H, R, Z. So R is also hepatitis, hepatotoxic, and it causes the secretions orange red secretion. All the secretions become orange red, like the tears, like the saliva, like the vaginal secretion. All the secretions, genital secretions become orange red. So you have to warn the patient, if you take this tablet, the tears, the eyes, the tears coming can be red. It is not blood. Don't worry. The urine can be red. It's not blood. It's okay. So it can be orange red secretions. Okay. So coming on the third one, Z. We are done with H. We are done with R. Coming on the Z. The third one. We will make a master table in the end. Please be with me. So coming on the third one. Okay. The third one is the pyrazinamide. Parasympathomimetics is also Sidal, but weak Sidal. But it is also Sidal. It kill only intracellular, not extracellular. Till now, both of them, H and R, were killing intracellular as well as extracellular bacteria. But this one kill only intracellular. What is the mechanism of action? It inhibits FAST1 enzyme. So no FAST1, no mycolic acid, no cell wall. So the bacteria will die. So that is the mechanism of action. Adverse effect, it also causes hepatitis. Maximum hepatitis among the three. H, R, Z mein maximum hai. Okay. But it causes hyperuricemia. It increases uric acid in the blood. It decreases uric acid excretion so that in the blood uric acid will be more. So that is hyperuricemia and that can lead to gout. So please see. H, R, Z, E, S. Don't change the sequence. If you take the drugs in the sequence, the life will be easy. Okay. For hepatitis, the first three causes hepatitis. H causes hepatitis, R causes hepatitis, Z causes severe hepatitis. These do not cause hepatitis, the remaining two. Okay. But Z is a common thing. Z and E leads to hyperuric acid. That is gout. Okay. The first two and the last do not lead. So hyperuric acid occurs in Z and E. Okay. And hepatitis occurs in the first three. This is how you can learn. In the master table, you will see. So here it causes hyperuricemia. Okay, the next one is ethambutol, the fourth one. H, R, Z is done. Now coming on E, the fourth one. The fourth one is E. Okay, so it is only drug which is bacteriostatic. It is not Sidal. Rest all are Sidal, but this is cytic, and it is the least toxic among the five. Among the five, it is the least toxic. Please learn. It inhibits an enzyme arabinosyl transferase. arabinosyl transferase. So no arabinosyl transferase, mycolic acid will be synthesized because fast 1 and fast 2 are normal. Mycolic acid will be there, but what is the use? Mycolic acid cannot alone make the cell wall. Here arabinogalactone will be missing. So if mycolic acid is present but arabinogalactone is not there, ultimately cell wall will be not formed. The bacteria will not die, but at least it will not divide. It will not divide. It is bacteriostatic. Side effect, learn 3 side effect apart from hypersensitivity. Learn 3 side effect. Number 1, optic neuritis. It causes optic neuritis. Optic neuritis means the person can have green vision, but that's reversible. Number 2, increased blood uric acid. I told you these 2 causes increase uric acid in the blood, that is gout. And CNS. CNS may headache, dizziness, confusion can be there. The last one, streptomycin. Don't worry, if you have confusion, we will summarize in the master table. Okay, don't worry. So coming on the streptomycin, the last one, the fifth one. The fifth one is the streptomycin. So it is the first anti-tubercular drug to be discovered. And nowadays it is shifted to the second line. So in the first line, we have only 4 drugs now, HRZE. The S is shifted to the second line. It is also bactericidal, but it kill only extracellular bacteria, not intracellular. The mechanism of action you already know. It act on 30S as well as 50S as well as junction, and it inhibit the P window. So no initiation. So it will kill the bacteria, no protein synthesis. Adverse effect, I already told you in aminoglycoside if you are attending my lecture from the beginning. Okay, I taught you aminoglycoside in detail. If you have missed the initial portion of the lecture, please watch the recording later on. Please watch the protein synthesis inhibitors. I taught you 4 drugs there. Nucleic acid synthesis inhibitors, I taught you 3 drugs there. And after that, I'm teaching you anti-tubercular drugs. So here the mnemonic is ONN on HT. O for ototoxicity, N for nephrotoxicity, one more N for neuromuscular blockage, H for hypersensitivity, and T for teratogenic. Please learn that. So we are done. Can you help me in filling this table? Then we will solve some questions based on anti-tubercular drug. Are you people with me? Can I start filling? Okay. So HRZES. I guess you know the full form. Isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. Streptomycin is an aminoglycoside. So all of them are acidyl except ethambutol, which is static. The first thing. Okay. Now, which kill intracellular, which kill extracellular, which kill both? So this kill both, intra plus extra. This kill both, intra plus extra. But pyrazinamide kill only intracellular. And streptomycin kill only extracellular. Ethambutol also kill both intra plus extra. The second thing you have to compare this. So please learn here, this one is unique, which is static, rest all are acidyl. Here, these 2 are unique. This kill only intracellular, this kill only extracellular. Rest all are same. What is unique? You have to learn that. Okay. Now tell me the earliest, which act earliest to make the patient non-infectious. So earliest among them is this. But which is most potent, most potent to kill the bacteria and make the patient sterilization. So most potent, most powerful is rifampicin. So please learn, earliest is isoniazid, but most potent is rifampicin. You have to learn that. Okay. Anything extra? Anything else you have to learn? So this is the common points you have to learn in the introduction. Now, mechanism of action. So first tell me, this inhibits cell wall synthesis. This also inhibits cell wall synthesis. This also inhibits cell wall synthesis. Okay. Rifampicin R for R. It inhibits RNA synthesis. And streptomycin, since it's an aminoglycoside, it inhibits protein synthesis. Now tell me the enzymes. So isoniazid inhibit fatty acyl synthetase 2, fast 2. Okay. Pyrazinamide inhibit fatty acyl synthetase 1, fast 1. So mycolic acid will not be formed here also. And ethambutol inhibit arabinosyl transferase. So arabinogalactoside will not form. Ultimately, cell wall will not form. Here for RNA, the enzyme is DNA dependent RNA polymerase. DNA dependent RNA polymerase enzyme is inhibited. And here enzyme is not there, but here the P window is inhibited. So initiation will not be there. Initiation will be freezed. So that is the mechanism of action. And here 30S, 50S as well as junction will be affected in the ribosome. Okay, now coming on the adverse effect. Now tell me the main adverse effect of each of them. Hypersensitivity is in all of them. Apart from that, you tell me the adverse effect. So hepatitis. Here mild, but here severe hepatitis. Okay, here uric acid is raised and patient have the gout, and here uric acid is raised, patient have the gout. So in pyrazinamide, both of them are there. So this is the common one. Apart from that, here 2 more are there. One is peripheral neuritis and one is hemolysis in G6PD. So peripheral neuritis because of pyridoxine synthesis inhibition, interference. So that is the 3 side effect of H. Coming on R, what was the other side effect of R? Can you help me in revising? What was the other side effect of R? Apart from hepatitis, what was that? Rifampicin, it was orange red urine. So orange red secretions are there. Okay. Paracetamide have only these two important side effect. Here optic neuritis is there. And CNS में dizziness, headache, all that. Streptomycin, you know the mnemonic on, O-double-N on HT. So it is ototoxic, neurotoxic, nephrotoxic, hypersensitivity, and teratogenic. Please learn that. Anyone have any confusion? Can we solve the questions? The main points are covered. The anti-tubercular drugs. This is how you have to approach. Give me a thumbs up. So read the question and tell me the answer. Which of the following anti-tubercular drug may precipitate gout? Gout matlab increase in uric acid. I told you there are 5 HRZES. Among them, the third and the fourth. That is these two. These two have uric acid increase. So whatever is given in the option among the two. Among the two, I can see paracetamide is given, but ethambutol is not there in the option. So the correct answer is paracetamide, and you all are right. I want everyone to say the correct answer and quickly. Yes, the correct answer is A. You all are right. Please, yes, absolutely right. Mantis, absolutely right. What about others? Please say the answers. So the correct answer is A, and you all are right. The next question is in front of you. All of the following are examples of bactericidal drug. Except which of the following is not bactericidal. You can see the options are anti-tubercular drugs. So I told you among the 5 HRZES, all of them are cidal except ethambutol, which is static. So the correct answer here is ethambutol, and you all are right. You all are right. I hope you got it. Okay. The next question is in front of you. Read the question. There is a person on anti-tubercular drugs. There is a person on anti-tubercular drugs complain of deafness and tinnitus in 1 year. Okay. The drug which is responsible. So remember the side effect of streptomycin. The mnemonic is on HT. What is O? O is ototoxic, and they are talking about the ototoxicity. Deafness and tinnitus means it indicates ototoxicity. That's why the correct answer is A. You all are right. Absolutely right. Absolutely right. The next question is in front of you. Anti-tubercular drug which makes the patient non-infective earliest. Which anti-tubercular drug makes the patient non-infective earliest? Very early. Earliest. So they are asking the earliest, not most potent. So earliest is isoniazid. But if I change the question, instead of earliest, if I ask the most potent drug to sterilize and kill the bacteria, the answer will be rifampicin. In that case, I hope you got it. I hope you got it. So how was the antimicrobial drugs? So I have completed the antimicrobial drugs, the main antimicrobial drugs I have completed, which are ultra important for revision before going your exam. How was it? Was it useful? Yes, no, say something. You want more systems to be revised right now? Say something. Huh? So we will take a small break of 15 minutes. After that, we will continue the class. Okay, so I will start with the endocrine. The next is the endocrine. In the endocrine, I will teach you the drugs for the diabetes. So first, I will teach you all about the insulin. You very frequently get the question of the insulin. It's a small topic. After that, the oral hypoglycemic drugs, OHAs, the various oral hypoglycemic drugs. After that, I will take the respiratory system. I will teach you the drugs for the asthma. I will take the CNS. I will take you sedatives, hypnotics, and anti-Parkinsonism drugs. So these are the systems that we will take today. Okay, CVS we have already taken, renal we have already taken. In the last part you can check. Okay, chalo. So let's take a small break. Let's take a break for 15 minutes and I will be back in 15 minutes. So currently the time is 11:15. I will be back at 11:30. So break time. Break time for 15 minutes here only in the same link. Okay, it's break time. So please be on time and don't go anywhere. It's a small coffee break and we will be back. And after that, we will continue ahead the more systems. So 15-minute break. Okay. Hello everyone, am I back? I guess I'm visible, audible. Yes, it's working. So let's continue. Okay, Chalo. So let's continue. So we have already covered antimicrobial drugs in detail, and now it's time to start with the endocrine system. So in the endocrine system, the most important drugs I would like to cover here is the drugs for the diabetes. Diabetes mellitus. So I will cover two things here, two drugs here. Number one, insulin. We will see all types of insulin, everything about the insulin in detail, and then we will come on the oral hypoglycemic drugs. Believe me, you get many questions from this section. But before understanding the drugs for the diabetes, you can't understand them if you don't understand diabetes. So first of all, it's important for us to understand the pathogenesis for the diabetes mellitus. What are the two type of diabetes, type 1, type 2, and then we can understand their drugs very easily. So let's start diabetes mellitus. Diabetes mellitus. So let's start the topic diabetes mellitus. Okay, I'm starting the topic diabetes mellitus. Then I will teach you the drugs. In the next 2-3 minutes, we will finish the pathogenesis and then you will have a better understanding for the drugs. So diabetes is a disease of the pancreas. Humans have a pancreas. Pancreas is the organ present in the abdomen. Anatomically, it's a one organ, but functionally it's a dual organ. It is having exocrine part and endocrine part. Currently I'm interested in the endocrine part. Okay, there are cells inside the pancreas which are known as islet of Langerhans. The islet of Langerhans is a collection of 4 types of cells. What are the 4 types of cells present inside islet of Langerhans of the pancreas? Alpha cell, beta cell, delta cell, and pancreatic polypeptide cell. They all secrete hormones. Alpha cell secrete glucagon, beta cell secrete insulin, delta cell secrete somatostatin, and pancreatic polypeptide secrete pancreatic polypeptide. Currently, I'm interested in the first 2 cells, alpha and beta. So let me explain you, because alpha and beta maintain the homeostasis of the glucose between the cell and the blood. Now have a look on this diagram. Everyone, please concentrate on your gadgets and see the diagram. Can you see in the diagram? In the diagram, what you can see? You can see this is blood, human blood, and this is human cell. So you can see the glucose, the transfer of the glucose from blood to cell and from cell to blood. 2 hormones are required. See, look at the arrows. Insulin is a hormone which is secreted by the beta cell of the pancreas, of the islet of Langerhans of the pancreas, and it is transmitting the glucose from blood to cell. So it is decreasing the blood component, the blood glucose level. Insulin decreases the blood glucose level because it is transmitting the glucose from the blood to the cell and it is stored inside the cell in the form of the glycogen. Okay, glucagon is doing the reverse. What the glucagon is doing? Glucagon is splitting the glycogen and transmitting the glucose from the cell to the blood. So glucagon is increasing the blood glucose level. So whenever we eat food, just suppose I eat 3 meals. I eat my breakfast, I eat my lunch, I eat my dinner. So normally people eat 3 major meals. So breakfast, lunch, dinner. Whenever we eat anything, everything contains glucose, although less or more, but everything contains glucose. So whenever we eat anything, the glucose get absorbed in the blood. So after eating immediately, the blood concentration of glucose is very high. At that time, we have to reduce it. So whenever we eat, insulin automatically come in the blood and take all the glucose, the extra glucose from the blood into the cell and store it. So after eating, insulin secretion takes place. But suppose I'm fasting the complete day. I have not eaten anything since the last 10 hours, 15 hours, okay, 24 hours. I'm fasting due to any reason, maybe due to any reason. So my blood glucose level may fall. My body do not want that. My body want to maintain the blood glucose level, the basal level. At that time, glucagon will come in the role. So at the time of the fasting, the glucagon will come in the role. At the time of the eating, insulin come in the role. I hope you can understand the basic physiology. So this is the thing. So insulin convert the glucose to glycogen and store it in the cell. Glucagon does the reverse. It split the glycogen into the glucose and take it into the blood. So I guess you can get it. Now, what is the problem in the diabetes? In the diabetes, insulin is absent. Either of the two things. Either the insulin is absent, like in type 1 diabetes, or it is present but non-functional. That is in type 2 diabetes. The type 2 diabetes, insulin present but non-functional, and that is known as insulin resistance. So insulin, either it is absent, like type 1 diabetes, or it is present. I believe it is present, but it is non-functional. That is type 2 diabetes. That is insulin resistance in both the scenario. So this transfer will be inhibited. Okay. So glucose will not transfer from blood to cell. So glucose concentration in the blood will be high. So when the glucose concentration in the blood will be high, because it is not transmitted to the cell concentration of the glucose will be low because insulin is not working. Insulin is not there. It is not present. So glucose concentration in the cell is high. It is known as hyperglycemia, and that is known as diabetes. So diabetes is a group of disorder in which the patient presents with hyperglycemia. So what is diabetes mellitus? In diabetes mellitus, 2 things happen. Either insulin is absent or it's non-functional. And that's why the blood have a trouble in moving the glucose, body have a trouble in moving the glucose from blood to cell. So two things are there, two problems. Number one, blood mein glucose high hai, that is the problem. And number two, the body is not getting, the cells are not getting the glucose. There is less glucose in the cell. The cells are starving of the glucose. Both are problematic. Blood contain high glucose, that is a problem. And the cells are starving of glucose. So although abundant of glucose is present in the blood, the cells cannot utilize that. Have you heard a proverb in Hindi? Kabhi suna hai Hindi mein? Samundar tale pyasa ya diya tale andhera. Have you heard that? What do you mean by that? So there is abundant of glucose in the blood, but the cells cannot utilize that. That is a problem in diabetes mellitus. That is happening here. Okay. So cells are starving. Cells have less glucose and the blood is full of glucose. That is hyperglycemia. That is the two things which is happening in diabetes. Okay. Now you have to understand the insulin regulation if you want to understand the various types of insulin and the mechanism of action of various oral hypoglycemic drugs. So how does insulin get synthesized, how it is released, and what are the action of the insulin? You have to understand normally, physiologically. Have a look on this. So in this diagram, the GIT of a human is shown to you. Imagine I am the person shown here and I am eating a meal. So I am eating food. I am eating any meal. It can be breakfast, it can be lunch, it can be dinner. So whenever I eat anything, it contains glucose. So whatever I am eating, the glucose get absorbed and reach in the blood. Okay, it is reaching in the blood. So red colored dots is the glucose. So glucose is reaching in the blood. When the blood concentration of the glucose is more than 80, when the blood concentration of glucose is more than 80, that will go to the pancreas. That will go to the pancreas. And in the pancreas, it is going to the beta cell. There are alpha cell, delta cell, but it is going to the beta cell and it is knocking the beta cell. So this glucose will enter inside the beta cell with the help of receptor. The name of the receptor is GLUT2. With the GLUT2, this glucose will enter inside the beta cell when it is more than 80. When it is more than 80 milligram per deciliter, it is entering inside the cell. After entering inside the cell, the glucose will convert into glucose 6-phosphate. Okay. And the ATP is released. That ATP will block the potassium channel. Since the potassium channel will be blocked, there is a potassium channel on the beta cell. Since the potassium channel will be blocked, that will lead to hyperpolarization of the cell membrane of the beta cell, the hyperpolarization, and because of which the calcium channels get stimulated and calcium will come inside. When the calcium will come inside, the insulin granules will fuse and insulin will be secreted in the blood. And this is how insulin come in the blood. You can't understand the mechanism of action of oral hypoglycemic drugs if you don't understand this. You have to understand the physiology. So this is a cell, a beta cell, which is present inside the pancreas. It is having three transporters on that. One is GLUT2, one is potassium channel, ATP sensitive potassium channel. The name is ATP sensitive because ATP can block that. ATP sensitive potassium channel, and one is calcium channel. So when the blood glucose level is more than 80, the glucose will come here and enter from here. Once the glucose go inside, it will convert into glucose 6-phosphate. During this, an ATP is secreted or released. This ATP will block this channel. That's why the membrane, because this is blocked now, the membrane of this will get hyperpolarized. That will cause activation of calcium channel. Calcium will come inside. I'm sorry, just a second. How it will go? Just a second. Give me a minute. I guess you can see it normally now. I can't see the screen. Just a second. Drag it. Anyways, we will continue like this only. You can see the screen on this, okay? Done. Okay, I'm sorry. Okay, yes. So here you can see like this, and the insulin is secreted like this. The insulin will come in the blood. Now what the insulin will do? Insulin will go to the three target organs. These are known as three target organs. It's liver, skeletal muscle, and adipose tissue. These are the three target organs. On these three target organs, the insulin receptor is present. Insulin receptor is a tetramer. Can you see the blue color is the insulin here? The blue color is the insulin here. The insulin will go to its target organ, that is liver, skeletal muscle, and adipose tissue, on which the insulin receptor is present, and insulin will bind with its insulin receptor. The insulin will bind with its insulin receptor and open the GLUT4. Okay, GLUT4 is present in the cytoplasm of these cells. It will cause the movement of the GLUT4 from the cytoplasm on the cell membrane, and GLUT4 will open and the glucose will enter in these cells via GLUT4. Now please imagine if insulin is not there. If insulin is not there, glucose directly trying to enter in these cells and getting stored in these cells, the gate will not open. The GLUT4 will not open. These cells will say, first you open the door, GLUT4, with the help of insulin, then you come inside. So you can say the insulin is a key for the door via which the door will open and glucose can enter. So this is the story in short. I hope you got it. You can see the same here. This is a beta cell. You can see this is GLUT2. When the glucose level is more than 80, it is entering inside. It is converting to glucose 6-phosphate. The ATP is released. ATP will block the potassium channel. So potassium normally come inside. It will not come inside, and the potassium concentration inside the cell will fall. That will cause the hyperpolarization of the cell, and that will activate the calcium channel. Calcium will come inside, and that will cause the secretion of the insulin in the blood. And this is how the things takes place. I hope you got it. In the 3 organs, what are the 3 target organs? It is liver, skeletal muscle, and adipose tissue. The glucose gets stored. So here the glucose gets stored in the form of the glycogen, here also glycogen, and here in the form of the fatty acid. The glucose gets stored. The glucose gets stored here. Okay, so this is the complete story. Now, what is the problem in type 1 and type 2 diabetes? In type 1 diabetes, it's only 10%. Type 2 diabetes is 90%. Type 1 diabetes is known as juvenile onset diabetes. Type 2 diabetes is known as maturity onset diabetes. So in type 1 diabetes, the insulin is absent. The insulin is absent because of the self-immunity, self-tolerance, or autoimmunity. The beta cells are killed. Who is destroying the beta cell? The beta cell is destroyed by the self T lymphocyte. Normally T lymphocytes are soldiers. Okay, they kill the foreign particle. I'm having T lymphocyte, I'm having B lymphocyte, but they are not self-reactive. They kill the foreign particle. Whenever foreign particle enters in my body, they kill that. They get activated and kill. But sometimes they get auto-reactive. They get self-reactive. Okay, they start killing body's own tissue. So these are the self-reactive cytotoxic T lymphocyte. In some individuals, they kill the beta lymphocyte. So they keep on killing. One point will come, beta cell will become 0. 0 beta cell, 0 insulin. So these are the person have 0 insulin in their blood at one time. So usually at the time of the adolescence, this picture will come. At the time of the adolescence, this picture will come. And there will be 0. There will be, you can say, it's completely there will be 0 insulin. So no insulin will be there. That will lead to hyperglycemia, and that is type 1 diabetes. What will happen in type 2 diabetes? In type 2 diabetes, there is no problem in beta cells. Beta cells are absolutely normal. They are secreting the insulin in the blood. You will say, ma'am, then what is the problem? The insulin receptor is the defective. Okay, so insulin is going to its receptor, but receptor is non-functional, not responding. So it is not opening the door. It is not opening the GLUT4. So although insulin present in the blood, but it is non-functional. It cannot function. It is going and binding on its receptor. The receptor is not responding. So the GLUT4 is not opening. That is type 2 diabetes, and that is known as insulin resistance. I hope you got it. The detail you will see in the pathology, but that much is sufficient for understanding the drugs. So I hope you got the 2 type of the diabetes, type 1 and type 2. Okay, say yes. Got it. So in type 1 diabetes, the problem in the pancreas, and in type 2 diabetes, the problem in the target cells. That is liver, skeletal muscle, and adipose tissue. This is the problem. Okay, now let's start the insulin. And now you are ready to study the insulin and oral hypoglycemic drugs. Give me a thumbs up. Can I start insulin? So how many types of insulin are there? We divide the insulin into 4 categories. What are the 4 categories? Conventional category, highly purified or monocomponent insulin, human insulin, or insulin analogs. So these are the 4 categories. Conventional insulin, it is prepared from the beef and the pork. Beef means cow, pork means pig, and it is highly antigenic. It's highly antigenic because it is prepared from different animal pancreas. So we take the beef, cow, we take the pig, we kill them, we take their pancreas out, we take their beta cells, we extract the beta cell, and from the beta cell we extract the insulin, and that we use for the humans. So it is antigenic, it is highly antigenic. We are taking it from different animal, different species, and it is not used nowadays. No longer produced because it is highly antigenic. Many hypersensitivity reactions are there. So we don't use nowadays. This is the old conventional one. After that, it is highly purified or monocomponent. It is the purified version of this only. So here we were using as it is. Here we are purifying them and then using it. Still, it is highly antigenic. So we do not use them also. But these 2 we can use now. So this is the human insulin, and this is the insulin analog. Human insulin is prepared from humans only with the help of DNA technology, recombinant DNA technology in E. coli and yeast. We use the insulin gene of the human. Okay, with the help of the vector, we insert that gene in the E. coli and yeast, and we produce the same insulin as the top human. Okay, and insulin analog, we do certain modifications for better glycemic control. So these 2 insulin we use nowadays. So let me tell you the classification of the insulin. Okay, how many type of insulin we use nowadays? Nowadays, we don't use conventional, we don't use this one. Highly purifiable, we use this one. So these are the insulin. So we divide the insulin in 4 categories. What are the 4 categories? Rapid acting, short acting, intermediate acting, and long acting. Instead of rapid acting, you can say ultra short acting. Ultra short and rapid is same. You can say ultra short, short, intermediate, long. So ultra short and short is different. Okay, ultra short and short is different. Okay, so what is The basis of classification after insulin is always injectable. It is not tablet. It is always injectable. Subcutaneous injection is given. So after subcutaneous injection, after how much time, how long time they come in their role, the maximum activity or they come their role. So that is the basis of their classification. So short acting, intermediate acting, ultra short acting, intermediate acting, and long acting. In the ultra short acting, we are having 3 insulin: Lispro, Aspart, Glulisant. Okay, you can learn the mnemonic LAG, lag, Lispro, Aspart, and Glulisant. All contain S. Lispro spelling contain S, Aspart containing spelling contain S, and Glulisant also contain S. You can learn the spelling contain S so that it will be easy for you to search them in the option. Lispro, Aspart, Glulisant, all of them contain S, S, S. Their spelling contain S. Okay, these are the 3 ultra short. In the short, we have only one insulin, regular insulin, also known as soluble insulin. That's it. In the intermediate, we have 2. In the intermediate, we have insulin zinc suspension, known as lente insulin, and we have neutral protamine head-gone insulin, NPH, also known as isophane insulin. So these are the 2 insulin. Okay, here we have insulin zinc suspension, lente insulin, and isophane. Lente and isophane insulin, the 2 insulin. Here we are combining the insulin with zinc, and here we are combining the insulin with protamine. So that is, we are combining the insulin with something. That is intermediate acting. Okay. And in the long acting, we have glargine, detamar, and degludec. So glargine, detamar, and degludec. You can learn the mnemonic GDD. Okay. Glargine, detamar, and degludec. So these are the 3 long acting. So please learn all types of insulin. What is the classification of insulin? We divide the insulin in 4 categories. Insulin. We are dividing the insulin in 4 categories. What are the 4 categories we are having? We are having ultra short insulin, ultra short acting, we are having short acting, we are intermediate having, and having long acting insulin. Okay, in the ultra short, we are having Lispro, Aspart, Glulisant. All of them contain the suffix S. Okay, short acting, only one regular. Intermediate acting, we are having 2. We can combine the insulin with zinc, or we can combine the insulin with protamine. So this is known as lente insulin, this is known as isophane insulin. And the long acting, we are having glargine, this is Glulisant, this is glargine, detamar, and degludec. So they all contain the suffix, one of the word as R in their spelling. This is how you can recognize them. It's very easy to learn the classification. Now, most of the question MCQ you get from the classification itself. You get the name of the insulin. They can ask you the classification, which of the following is ultra short, intermediate, or long. So you should know this classification very well. Insulin. Now I will tell you the main properties of each of them. Let's start the short acting. Short acting. I'm directly coming on the short acting. Okay, short acting may we have a regular insulin. It's having neutral pH. It is stabilized by adding small amount of zinc here. You can see here, this is the insulin. We are adding a small amount of zinc. So insulin can be monomer, and some of the insulin can be hexamer around this zinc, which is not combined with the zinc. It's a monomer, which is combined with the zinc. It is forming a hexamer. The monomer is absorbing fast, and the hexamer is absorbing slow. So overall, if you take the average, it will be short acting. It is not ultra short, it's short acting. So we are adding a small amount of zinc. Okay, because if we don't add zinc, all of them will be monomer, and it will be ultra fast. It will be ultra fast. If you want ultra short, if you want to make short, add little bit of the zinc so that some of them form the hexamer. It's like that. Okay, coming on the intermediate acting. In the intermediate acting, we are having 2. We are having lente and we are having isophane. In the lente, we are combining the insulin with abundant of zinc. You can see here, this is the hexamer. These are multiple hexamers. You can see. So it can be long particles or small particle chain. Okay. So this is lente insulin, and in isophane, we are combining it with the protamine. That's it. Okay. You can see like that. Now coming on the rapid insulin, I mean ultra short. In the ultra short, we are having 3: Lispro, Aspart, and Glulisant. To understand the modifications which are done here, you have to understand normal insulin. In a normal insulin, we are having 2 chains: alpha chain and beta chain. You can see alpha and beta chain. You can see it here. Okay, alpha chain and beta chain, you can see it here. So in the alpha chain, there are 21 amino acids. In the beta chain, there is 30 amino acids. Total 51 amino acids are there. We will do certain modifications here so that it will get modified and it will become ultra short. So how many insulins are there in the rapidly acting? We are having 3 insulin: Lispro, Aspart, and Glulisant. In the Lispro, we are doing modification in the beta chain. In the beta chain, total 30 are there now. At beta chain 28 and 29. 28 and 29, we are reversing the positions. You can see at 28 and 29. This is beta chain. You can see the pink color chain is the beta chain. So appreciate the last this is 30 se pehle, this is 28, 29. Normally, it's proline followed by lysine. So proline is at, you can see, just a second, proline is present here and lysine is present. So we are reversing the sequence. Instead of proline and lysine, it's lysine and proline. Lysine and proline. We are reversing the sequence. Proline or lysine ki jagah, we are doing lysine and proline. That's it. And that is Lispro. So in Lispro, we are doing the changes at beta chain 28 and 29 and we are reversing them. Instead of proline and lysine, we are doing lysine and proline. That's it. You can get MCQ on that. Okay. In the S part, we are doing change only at beta 28. Beta 28. Normally it contains proline. Na? I told you. We are replacing the proline with aspartic acid. You can see here only. We are replacing the proline with aspartic acid. That is aspart. Since we are replacing the proline with aspartic acid, it is aspart. It is aspart. Okay, we are replacing with aspartic acid. And the third one is the glulicin. In the glulicin, again, we are doing two changes. One at beta chain 23 and beta chain 29. Okay, beta chain 23 have lysine. We are replacing it with arginine. So where is 23, 21, 22, 23? At 23, normally it's lysine. We are replacing it with arginine. And at 29, we are replacing glutamic acid with the lysine. So this is the changes you have to learn. So all the changes are at beta chain only. The changes are not at alpha. You don't get a much difficult question in your exam. Okay, you will get an easy question, but you should know all the changes at the beta, and broadly you should know the changes. It can be an image-based question also. Okay, so that is the short acting. So, and these are the long acting. In the long acting also, we are doing certain changes here. Okay, so here you can see this is the classification, final classification of the insulin. There is rapid acting, short acting, intermediate acting, long acting. The names are written in front of you. The rapid acting contain the three: Lispro, aspart, glulicin. Short acting contain only one, regular. Intermediate acting containing two, lente and isophane. And long acting containing three, glargine, detimer and degludec. See, the short acting, ultra short acting is known as ultra short acting because they start showing their action. Onset is within 15 minutes. So just before eating 15 minutes, they have to be applied. Within 15 minutes, they show their action. Short acting show their action between half to 1 hour. That's why short. Intermediate act, 2 hours. Intermediate require 2 hours to show their action. Onset of action. And long acting show their action after 4 hours. 4 to 6 hours. So you can see the onset. Okay. Now, most important, you have to learn here, only regular insulin can be given IV. Rest all has to be given subcutaneous. Only regular has to be given IV. Please learn that. You get question on the regular insulin. It can be given IV also in case of emergency. You can give directly IV, but rest all the insulin has to be given subcutaneous. Okay, it's an MCQ, the regular insulin, which is a short acting. One more question you get on glargine. Glargine is an insulin whose pH is 4. So it cannot be mixed. It cannot be mixed with any other insulin preparation. Must be injected separately. The others we can mix together because they have the same pH. But here the pH is 4. The glargine cannot be mixed with others. So you get a question here also. You have to learn the important questions. So route, I told you there are 2 routes to give the insulin. Maximum route is subcutaneous only. You have to give subcutaneous only. Only one of them can be given IV. That is regular insulin. It can be given IV also. Rest all has to be given subcutaneous. We have to be given subcutaneous, and how to be given. So subcutaneous, it can be given around the abdomen. You can see, Hana. You can see 2 feet away. You can see around the abdomen. You can see here 2 inch. You can see 2 inch. You have to see, leave the space of 2 inch, and around that, everywhere else it can be given on the abdomen. It can be given on the thigh, lateral and outer aspect of the thigh. Okay, it can be given on the arms also, like that. Okay, so this is the areas where the insulin can be given subcutaneously. So for giving the subcutaneous, we have to make a fold and insert the injection at 90 degrees, the subcutaneous injection. This is how it has to be given. It's like that. It can be given in the abdomen. It can be given over the thigh. It can be given on the arm. It can be given on the, like that, thighs also. Okay, so that is how it is given. Okay, so these are the important things you get questions from the insulin. Read the question and tell me the answer. Regular insulin, which of the following is the intermediate acting insulin? I told you the classification of the insulin: ultra short, intermediate and long. Ultra short, intermediate and long. The 4 type of the insulin. Okay, you tell me which of them is intermediate. In the intermediate, I taught you 2 insulins are there, na? One is lente, where we combine the insulin with zinc, and one is isophane, also known as NPH, neutral protamine hedge, where we combine the insulin with the protamine. So correct answer here is NPH. Yes, absolutely right. The correct answer is the NPH. Okay. So you get many questions. If I change the question, which of the following is short acting, answer will become regular. Which of the following is ultra short acting, answer is become Lispro. Which of the following is long acting, answer will become Glargine. So one insulin from each category is there. Okay. We can change the question many times. Read the next question. Which of the following is the long acting insulin that is never attained a peak concentration in the plasma? So which of the following is a long-acting insulin basically? Okay, long-acting never attain a peak concentration. They are always towards the basal side. So is it Lispro, Aspart, Glulicin or Glargine? Huh? Long-acting. So long-acting are three. Glargine, Detamar and Degludec. So Glargine, Detamar and Degludec are there. So correct answer is Glargine here. Got it, got it. Now I'm teaching you the oral hypoglycemic drugs to treat the diabetes. So let's start the oral hypoglycemic drugs. So this is the classification you can see. We divide the oral hypoglycemic drugs in three categories. Number one, which act on the pancreas, the beta cell of the pancreas, and enhance the secretion of the insulin. Enhance the secretion of the insulin that, okay. Number two, that can be not acting on the beta cell of the pancreas, that act on the target organ and overcome the insulin resistance. And third is miscellaneous. Third category is miscellaneous. Okay. So we will take them one by one. In the enhanced secretion, insulin secretion, insulin secretion takes place from the beta cell of the pancreas. We divide them in three categories. Potassium channel blockers. The first one are the potassium ATPase channel blocker, ATP sensitive potassium channel blocker. The second can be DPP4 inhibitors. I will explain what is DPP4 inhibitor. It is dipeptide peptidase 4 inhibitor. I will explain what does it mean. And third is GLP-1 analogs. So we divide them in three categories. I will explain you all these three categories. They are potassium channel blockers. I will explain you three categories here. After that, we will come to overcome the resistance of the insulin. These are the drugs that do not act on pancreas, that basically act on the target organs, that will act on the insulin receptor to overcome the insulin resistance. They will not increase insulin secretion. These are known as secretagogue because they increase this insulin secretion from the pancreas. These are not secretagogue. They decrease the resistance of the insulin, already present insulin. So here we divide them in two categories, biguanides and thiazolidinedione. So here biguanides and thiazolidinedione. So these are the one which decreases the resistance. So we will study them one by one. Okay, can we start? So let's start with the potassium ATPase channel blocker. ATP sensitive potassium channel blocker. Okay, so first of all, you should know the drugs in each category, mechanism of action and adverse effect. The use of all of them is diabetes itself. We are using in diabetes. Okay, so let's start the potassium channel blockers. As I told you, there are two types of potassium channel blockers. Here also you can see sulfonyl ureas can be there and maglitinide can be there. So sulfonyl ureas can be there and maglitinide can be there. In the sulfonyl ureas, all the G starting the drugs with the latter G is there. It can be glibenclamide, glipizide, gliclazide and glimepiride. So you can see GGG, glibenclamide, you can say with me glibenclamide, glipizide, gliclazide and glimepiride, you can see. And one of them is tolbutamide. We don't use tolbutamide nowadays. Okay. And in the maglitinide, it is repaglitin and natigliptin. Repaglinide and natiglinide. So these are two maglitinides are there. Okay, so we will see the mechanism of action of both of them is same. They inhibit the potassium channel, the ATP sensitive potassium channel. So normally, you know what happens, I have already explained you. So normally whenever we eat a meal, see, someone is eating a meal. So whenever we eat anything, the glucose is present in the meal. All the meal contain, it is breakfast, lunch, dinner. The glucose is going inside. The glucose get absorbed and reach the blood. Okay, they reach the blood. You can see the red color dot is the glucose. Whenever the glucose concentration in the blood is more than 70 milligram or 80 milligram per deciliter, that is a trigger. It will go to the pancreas. It will go to the beta cell of the pancreas. Let me zoom this cell on the next page. Okay, this one, the same cell. This is beta cell. So this glucose enter in the beta cell of the pancreas via GLUT2 receptor. And after entering, it will get converted to glucose 6-phosphate and ATP is secreted, and ATP inhibit the potassium channel because it is ATP sensitive potassium channel. Once the potassium channel is inhibited, potassium normally enters inside. It is not entering because this transporter is inhibited. So the membrane will get hyperpolarized. That will cause activation of calcium channel. Calcium will go inside. Once the calcium will go inside, it will cause the fusion of the insulin granules with the cell membrane and insulin will be secreted in the blood. In the blood, insulin will come. So what is these drugs are doing? I am teaching you sulfonyl ureas and maglitinide, both of them. Potassium channel blockers. What does they do? They directly inhibit this channel. So whether it is sulfonylurea or whether it is meglitinide, see both of them are written here. Sulfonylurea as well as meglitinide, both of them, they are inhibiting the ATP sensitive potassium channel. Same thing will happen, which is happening physiologically. Now this channel is inhibited, so potassium will not go inside. The membrane will become hyperpolarized. The calcium channel get activated. Calcium will go inside. It will fuse the insulin granules with the cell membrane. Insulin will come out. So these are secretagogue. They are secreting more and more insulin from the pancreas into the blood. So sulfonylurea and meglitinide, both of them, they block ATP sensitive potassium channel. They are blocking that. So inward flow of the potassium is restricted. It will cause hyperpolarization of the membrane. Okay, it will cause, I'm sorry, not hyperpolarization, depolarization of the membrane, and it will cause activation of the calcium channel. Calcium will go inside and it will cause the secretion of the insulin. These are secretagogues like that. What are the adverse effects? Sometimes insulin secretion is too high. Abundant of insulin will come in the blood, and that can lead to hypoglycemia. Hypoglycemia is a risk factor. Okay, non-specific side effects and allergy can be there, but hypoglycemia is a major risk factor. So we have seen the drugs, we have seen the mechanism of action, we have seen the adverse effect. The potassium ATPase channel blocker. Here two type of drugs are there: sulfonylurea, meglitinide. Sulfonylurea contain all G drug, glibenclamide, glipizide, okay, glimepiride, okay, and tolbutamide. And meglitinide drugs are there. The mechanism of action of both of them are same. They inhibit the potassium ATPase channel on the beta cells of the pancreas. They are acting on the pancreas. Adverse effect mainly hypoglycemia. Sometimes the patient can go in hypoglycemia. Now coming on the biguanides. Can I come on the biguanides? Let's come on the biguanide. Biguanide, how many drugs are there? First you enumerate the drugs. Two drugs are there: metformin and fenformin. Fenformin is banned because of high risk of lactic acidosis. It is withdrawn and banned in 2003. It is an MCQ. It is withdrawn and banned in 2003 because of the risk of severe lactic acidosis. It also causes lactic acidosis, but not very severe. So metformin is the only drug in this category nowadays. Fenformin is withdrawn. So only one drug is there in this category, that is metformin. What is the mechanism of action? It do not act on pancreas. It do not act on pancreas. Okay, listen what it is happening, what it is doing. It is decreasing the resistance of the insulin. Okay, so metformin interferes with cellular respiration in the mitochondria of the target cell. It goes in the target cell. These three cells. Metformin go in this cell, this cell, this cell. In the target cell, it interferes with the mitochondria. Inside the mitochondria only electron transport chain is there. Inside the mitochondria, it interferes with that. So intracellular, in the mitochondria only ATP is formed. Mitochondria is the powerhouse of the cell. Now if mitochondria is interfered, ATP, lowering of intracellular ATP will not form, and AMP will rise. AMP causes activation of an enzyme. The name of the enzyme is AMP dependent protein kinase. This protein kinase get activated. Now this protein kinase will do three things. What it will do? Three things. Number one, it will enhance insulin mediated glucose uptake and disposal in the skeletal muscle and the fat. So more and more glucose will be uptake in these target cell, and they will get stored. It will get stored inside this target cell. Number one, suppress hepatic gluconeogenesis, and number three, retards intestinal absorption of the glucose. So from the intestine, glucose will not be absorbed. Whatever absorbed, okay, it will get stored in the target organs, and the glucose will not form new glucose. The liver will not form the new glucose. That is, gluconeogenesis is suppressed in the liver. So three mechanism of action with this protein kinase. So what does metformin is doing? Metformin, it is acting on these target cell. It is not acting on the pancreas. If you remember, the sulfonylureas and meglitinides were acting on the pancreas, the beta cell of the pancreas. The metformin is acting on the target cell. It is interfering with the mitochondria of the three target cells, that is skeletal muscle, liver, and adipose tissue. So mitochondria is interfered, so ATP is not synthesized. ATP concentration will fall. AMP concentration will rise. AMP causes activation of an enzyme, that is protein kinase. And protein kinase enzyme will do three things. AMP dependent protein kinase will do three things. Number one, it will cause more and more glucose uptake in these target organs and store that. Number one. Number two, less absorption from the intestine of the glucose. And number three, less formation of the new glucose, synthesis of the glucose from the liver, that is gluconeogenesis. That is the thing. Adverse effect, it can be abdominal pain, anorexia, bloating, nausea, metallic test, the non-specific one. And vitamin B12 deficiency can occur. That's why the persons who are on metformin since long, the vitamin B12 supplement has to be. Okay, these are the adverse effects. So we are done with potassium ATP channel blockers. We are done with biguanides. Now the last one, thiazolidinedione. Let's come on thiazolidinedione. Here, how many drugs are there? Two drugs are there: pioglitazone and rosiglitazone. Rosiglitazone again banned in 2010. Why? Because of risk of MI, CHF, stroke. Because of the risk of MI, CHF, congestive heart failure, and stroke. It is banned. It is not used. It is banned in the market. So only one drug, pioglitazone. Okay, so we are having pioglitazone. So what does glitazone do? What is the mechanism of action of glitazone? The last one. Okay, what is the mechanism of action of glitazone here? So let me tell you the mechanism of action of the glitazones. These glitazones also act on the target organs. In these target organs, there is a receptor. The name of the receptor is PPAR gamma receptor in the target cells, mainly the adipose tissue cells. PPAR receptors, PPAR gamma receptors. So they bind with the receptors, they go inside the cell and they reach the nucleus of these, and there is a gene which is PPAR-Y gene. They stimulate that. So with the help of this, what will happen now? What exactly is happening? In the cytoplasm of these cells, the GLUT4 is present now. So we want the movement of the GLUT4. More and more GLUT4 should be translocated to the cell membrane. So with the help of this PPAR gamma gene stimulation, more and more GLUT4 will get transported to the cell membrane, and more glucose uptake will take place in these cells. And this is how, again, it is decreasing the resistance of the insulin. Okay, I hope you got it. So the adverse effect here is the fluid retention, weight gain, and precipitation of CHF. So you can learn the mechanism of action. Mainly question is on mechanism of action, the drugs and mechanism of action. Adverse effects are not very specific or important, but some questions on that also. So this is how we have completed the oral hypoglycemic agents also. How many of you got it? How many of you got it? So we have covered the most important systems in the entire pharmacology, I guess. Okay, so anything else from my side you want? Kindly write down in the comment box. How was the session? You found it useful? You found all the antimicrobial drugs today I taught you. I taught you many antimicrobial drugs today, and I taught you anti-diabetic drugs today. So that was a summary of the session, anti-diabetes drug today. So here we have covered the protein synthesis inhibitors, the anti-nucleic acid, the anti-tubercular drugs. Here I taught you the insulins and oral hypoglycemic agents. So these are the important points we have covered here. Okay, PDF I will share with the team. You will get it on the Telegram group. Okay, that's all. So thank you so much for your precious time, your attention, and if any other portion required by my side or any help is required in this session in pharmacology, kindly let me know in the comment box. So don't forget to give your review in the comment how you feel this session was. Was it useful for you? So I request you, if you have not watched episode 1 and episode 2 of the rapid revision, this is episode 3, please watch that. The remaining topics are covered there very beautifully in short and crisp, and all the MCQs are covered. So after watching that, you can make out most of the PYQs and MCQs based on those topics. So thank you so much. Thank you. Bye-bye. I'm ending the session. Bye-bye. Thank you so much.